the talk by Dr. Murlidhar. I know Dr. Murlidhar doesn't need any introduction, but he is a pediatric corneal surgeon at LV Prasad Eye Institute. He has been my great teacher, my great mentor, and I really owe a lot of, keratoplasties and other stuff in cornea to him and to Madam. That's Dr. Sunita Chaurasia. So with this brief introduction, I invite Dr. Murlidhar to give his great talk, that's selective endothelial removal. Dr. Murlidhar, all to you.
Yeah. Thank you, Dr. Alok. Much thanks for the kind words. I get started with my video.
Morning, myself Muralidhar Ramappa. I work at LV Prasad Eye Institute, Hyderabad, India. I shall be presenting our work titled Selective Endothelectomy in Peters Anomaly, acronym title SEPA. The long-term clinical outcomes in 34 eyes of 28 children with Peters Anomaly. None of the authors have any proprietary or commercial interests in any of the material discussed in this particular study. As we all know, Peters anomaly is the most common anterior segment developmental abnormality, presents with central or paracentral corneal opacification. It accounts for nearly 50% of the children born with corneal opacity. Bilaterality seen in 2/3 of the cases. Incidentally, it is also one of the most common indications for a corneal transplantation among congenital corneal opacity. This is a typical case of type 1 Peters anomaly with a posterior excavation, which is evident on an anterior segment OCT as well. In this particular instance, wider zone of cornea is involved. On UBM, you could actually see the perimeter of the corneal opacity having a synovial attachment, which is clearly evident on horizontal and vertical scans of the UBM. This is a typical case of keratoirodolenticular dysgenesis, where right and left eye of the same child, where left eye has a severe involvement with the cataract. While conservative approach applied in a milder variant of Peters anomaly, where surgical interventions are typically reserved in a severe cases of Peters anomaly, often have an abysmally poor outcome. While small subset of milder Peters anomaly tend to spontaneously recover over a time, but majority may not show a discernible clearing owing to presence of anomalous layer as shown in this particular slide. Histopathologically, the posterior defect filled with a uveal tissue and anomalous fetal membrane, as evidence in these histological slides. Perhaps this particular layer inhibits the normal endothelial migration, thereby preventing the spontaneous recovery. Based on our clinical as well as histopathological observation, we felt there is a focal area of anomalous Descemet's endothelial complex underlying the posterior defect, which perhaps serve as a contact inhibition. Once we remove those anomalous layer, the perilesional healthy endothelium tend to regenerate and fill the denuded area, lead to the resolution of the corneal edema. And also robust scar remodeling in children together with overlying well-preserved anterior stromal architecture helps in the rehabilitative journey of a child. We documented the postoperative healing response after SEPA using high-resolution anterior segment OCT. At 1 month postoperative follow-up, DM is not only well opposed, the endothelium was covering the defect, which is sharply demarcated. Together, clinically, we could actually perceive stroma is much more compact and transparent postoperatively. Our intent was to determine the functional success of SEPA in children with Peters anomaly. This was a single-center retrospective consecutive interventional case series. The study included 34 eyes of 28 children with visually significant Peters anomaly that had undergone a selective endothelial removal with or without additional procedure. The study was conducted at LV Prasad Eye Institute, Hyderabad, India, over a period of 80 years between 2012 and 20. Based on the location and extent of the corneal opacification, the corneal opacity can be categorized into the zone 1, which is a central island of corneal opacification within central 6 mm. Zone 2, central cornea with a peripheral cornea is involved. Zone 3A is a near total corneal opacification. Zone 3B, complete corneal opacification. This is a technique demonstrating selective endothelectomy. The integrity of Descemet's membrane. Step 4, checking the integrity of Descemet's membrane. There was no Descemet detachment at the end of surgery. Type 2 Peters anomaly, where an additional lens aspiration along with sphincterotomy was considered in view of a large corneal opacity. The sequential picture collage of a milder variant of Peters anomaly, right and left eye of a same child, showing the postoperative corneal edema resolution with a scar remodeling as observed over 18 months period. In contrast to the top row, wherein had an extremely good outcome with a smaller zone of corneal involvement, the bottom two rows had a wider zone of corneal involvement that resulted in a suboptimal outcome following this intervention, which was observed over a period of 6 months' time. The sequential picture collage of severe Peters anomaly, top and bottom row showing a significant improvement in eyes with a smaller zone of cornea. The middle two rows, where corneal opacity is much larger along with a cataractous lens, had a suboptimal outcome with a secondary glaucoma. Meaning even in a type 2 Peters abnormality, with a smaller zone of corneal involvement can help achieve a good outcome. Primarily, our cohort included type 1 abnormality. Median age at surgery was 7.2 months, and 85% had a discernible corneal clearance. So the 97% had ambulatory vision, and BCVA significantly improved owing to the resolution of the corneal opacification. On careful evaluation for the factors responsible for a SEPA failure, we found that one is severity of the disease, the zone of involvement, and additional intervention seems to be the important risk factor for the non-resolution of the corneal edema. 85% of the mild to moderate cases had a significant corneal clearing in comparison to the severe disease. The cornea tend to clear even beyond 12 months. So perhaps this may be related to the remodeling ability of the younger children. Over the last 3 decades, the literature primarily focused on anatomical success has shown a modest outcome, and only 20 to 60% of them achieved a 2400 or a better vision at a median follow-up of 4 years. The current study, where most cases have actually showed a significant improvement, and vision is continued to improve over a period of time. Our study validates the long-term outcome of SEPA. It's a novel, less invasive surgical strategy for the treatment of Peters. In 85% of the cases, opacity is significantly cleared with a marked improvement in the visual functions. We've also demonstrated to the best of our knowledge for the first time that SEPA can be used even in cases with the severe form of keratolenticule adhesion, as long as the central corneal opacity no more than 7 mm or at least half of the peripheral cornea has remained clear. The findings of our study questions the prevailing paradigm whether this procedure could be offered as a preferred surgical modality in every case of Peters anomaly, or only in a select cases where corneal opacity less than 7 mm, irrespective of the type of Peters anomaly. The long-term results are extremely promising, can be a very effective surgical alternative to penetrating keratoplasty. And this would benefit hundreds of children with Peters anomaly related corneal blindness worldwide. Thank you for your kind attention. Peters anomaly, acronym.
Thank you, Dr. Alok.
Yeah, Dr. Muralidhar, it's really a very novel and great technique that you have evolved. And in addition to that, the follow-up is, you have taken a good series for considering a good number of years, right from 2012. My, it's basically I have just two questions to you. One, though this is a very novel technique, but what is the outcome of the normal keratoplasty in such cases? That's one, the like full thickness penetrating keratoplasty in such cases. And secondly, what's your comment on the outcome of full thickness keratoplasty in patients with scleroderma?
Sclerocornea?
Sorry, sclerocornea.
Okay, nice question. So since I reviewed, 30 years of literature, what LV Prasad eye study actually shows, we have a little over 400 Peters anomaly which had a penetrating keratoplasty. And at the end of 1 year, only 1/3 of them have a clear anatomical outcome. And even if you have a clear cornea, because of 50% have a cognitive issues in a Peters anomaly, their functional success, only about a third of, about approximately 31% of them had a functional vision more than 2200. So therefore, each of these child, end up having a more than one keratoplasty in their lifetime. And subsequent keratoplasty have a much poorer outcome. Besides, they may have a cataract, and nearly 70% of them have a glaucoma risk, lifetime risk. So that may, warrants one more intervention. So it will be really tedious task for a parents to, take care of keratoplasty. By some other technique by which if we can really avoid corneal transplantation, it is the biggest boon, for particularly children with Peters anomaly. And also, Peters anomaly accounts for a 60% of all transplantation worldwide performed for a developmental abnormality of cornea. And yeah, that's the biggest advantage of this technique.
Okay, thanks, Dr. Muralidhar, for a great presentation. Due to shortage of time, I think we have to move to the next presentation. I'm really thankful to you and to see you in today's morning. Thank you, Dr. Muralidhar. A wonderful presentation. Now, second,
Thank you all.
Vijay is my colleague. He was my colleague in Army Hospital RNR, and a wonderful surgeon, a wonderful human being. And he'll be talking about the femtosecond assisted SALC, the technique, the modified technique which he has pioneered. So over to Dr. Vijay.
Thank you, sir. Am I audible, sir?
Yeah, you're audible.
Okay. So I'll be discussing about this technique, which we have called as TFALC. So TFALC is taking femtosecond laser assisted anterior lamellar keratoplasty. So this is for the management of superficial anterior corneal scars. What we had found that using a femtosecond laser with a conventional technique, that is FALC, where the side cut angle is kept at 90 degrees, the apposition of graft and host junction is not proper. If there is even a small mismatch, that creates a furrow whenever that when the cornea heals. So that is why we gave this technique, which is called as TFALC. I'll just be showing the video of the surgery and the various. A modified sutureless and glueless technique termed as tuck-in femtosecond laser assisted sutureless anterior lamellar keratoplasty, or TFALC. Many ocular pathologies primarily affect the anterior corneal layers, including Salzmann nodular degeneration, spheroidal degeneration, healed keratitis involving mainly the anterior corneal layers, and various types of anterior corneal dystrophies. SALC provides advantage of sutureless lamellar corneal surgery procedure to treat these opacities, minimizing potential complication of penetrating keratoplasty. Now, what are the options? Either a microkeratome assisted SALC or a femto assisted SALC can be performed. SALC performed using a microkeratome where a particular thickness blade is used for cutting the donor and recipient lamellar corneal buttons is done. Or the other option is femtosecond laser assisted keratoplasty, or FALC, where a programmed cutting of donor and recipient
lenticules can be done. Now the problems in these are the graft-host junction apposition. If the graft-host junction apposition is not proper, it can lead to altered biomechanics or other post-op complications, which include infectious keratitis, epithelial ingrowth, or many more. The graft-host junction is not appropriate. Hence, we have modified FALC to TFALC to achieve a good graft-host junction apposition and heal. TFALC was done using a Visumax femtosecond laser workstation. Energy setting of 36 was used with single spiral out scan direction and a track distance of 4.5 micron, spot distance of 4.5 micron, and the side cut angle was modified to 45 degree instead of conventional 90 degrees, as was described in previous techniques. The recipient corneal lamella is cut using the similar parameters. No oversizing of donor tissue by 0.1 millimeter is done, as was suggested earlier. Depth of donor lamellar cut was kept 10% more compared to recipient lamellar cut to cater for the swelling in the preserved media used. Diameter of donor and recipient lenticules were kept similar between 7.9 and 8.5. Now this is the preparation of a donor lenticule. After using a femtosecond laser, a blunt dissection is performed and the lenticule is removed. One can mark it for a proper orientation to the surgeon. This is a recipient lenticule is prepared using the similar parameter. A side cut is being made at 45 degrees. Now, after this has been done, the recipient lenticule is removed using a blunt dissection. And after the recipient lenticule is removed completely, then the donor lenticule is taken and is placed over the recipient bed. Once it is placed, the margins of the donor lenticules are slowly tucked under the recipient lenticule margins, which are prepared in the similar manner with a 45 degree cut. So there is a gap under the margins all around, and the donor lenticule is cut in those margins all around in 360 degrees. Once a good apposition is achieved, no glue is used and a bandaged contact lens is placed. This ASOCT pictures at 1 day, 1 month, and 3 months is showing the healing of the graft-host junction. Compared to a conventional technique where, with a 90 degree, where the graft-host junction apposition is not as good, you can see the gap and the slight tucking or a slight dent in the at the graft-host junction superiorly. The graft-host junction following TFALC has no uneven surface, as you can see in these photographs. These are some of the preoperative and post-operative photographs of the patient who have undergone TFALC. You can see the amount of clarity achieved in the preoperative and post-operative pictures and corresponding ASOCT. The visual acuity has shown marked or significant improvement in these patients. As shaped corneal transplantation, surgery is probably the way ahead for corneal transplantation procedure. Despite being technologically challenging and concerns of cost effectiveness, sutureless and glueless TFALC may lead to further improvement in biomechanics at graft-host junction following lamellar corneal transplantation for management of anterior corneal scars.
So the major advantage that we found by modifying this technique is the graft-host junction apposition. Here you are seeing the two ASOCT images of a normal FALC and a TFALC. Now you can see the healing. On the left side of the screen are the normal FALC cases, where you can see if there is a small mismatch, then there is a healing the furrowing occur at that junction, and which may impair subsequent healing and epithelialization and other aspects. Whereas in TFALC, you can see the 45 degree angle, and there is a large surface for the both surfaces to get healed, and it heals so well that the apposition is very good. You don't require a glue, and the healing is perfect. So that was the advantage of TFALC over a conventional femtosecond laser assisted lamellar keratoplasty. Any comments or any suggestions, please?
Yeah, Dr. Vijay, it was really a great presentation and a very innovative technique. And since I have seen the results, I think many of the patients have achieved even 6x6 vision. and many of them have achieved 6:9 vision. I think it's a very great and innovative technique.
Here, sir, I would like to acknowledge the contribution by my colleagues, including Dr. Alok Sati, Dr. Jaya Kaushik, and Dr. Santosh Kumar. During this refinement of this technique, they have helped me a lot. They have guided me a lot. So thank you very much once again for that.
Okay.
Thank you, Vijay. I have a question.
Yeah.
Can I go ahead, please? Am I audible?
Yeah. Please go ahead.
Dr. Vijay, what was your thickness for TFAL? The maximum thickness you could do in the TFAL?
We actually catered for the corneal opacities, which are up to 200 micron. So in 15 cases that we did, we have taken 165 is the thickest that we have taken of the host corneal thickness, which was opaque. That was 165. The thickest was 165 micron.
Okay. Any observation with the thick graft as compared to a thinner graft in your study?
In the thicker grafts, the healing is same as it was with the thinner grafts. Although the placement of BCL, we may have to continue for about 4 weeks in thicker graft as a precautionary measures. Otherwise, there was no difference. That was also, I think, we were apprehensive that graft is slightly thicker, so we'll wait for some more time for the healing to take place. And rest, there was no difference. Till 165, there was no difference.
Right. Thank you.
Thanks, Dr. Vijay. Now let's move on to the is Dr. Jagdeep is there? Dr. Jagdeep is there?
No, sir.
No. Dr. Srisha, are you ready for the presentation?
Yeah. Can I go ahead?
Yeah. Please go ahead. And I think what Dr. Srisha is going to present is about the DALC, the technique, complications and management. And we all have been doing it. And let's see what he has to give to all of us. Over to Dr. Srisha.
So, good morning. I would like, at the outset, I would like to thank Delhi Ophthalmic Society for the opportunity. And my presentation is on DALC, the surgical technique and management of some of the complications. May not be a great presentation for senior cornea surgeons. It may be useful for juniors and fellows who are starting this procedure. So it's a video-based presentation. We all know DALC is a surgical procedure that selectively removes pathological corneal stromal tissue down to Descemet's membrane and followed by transplantation of a donor graft without Descemet's membrane. The surgical procedure involves trephination, stromal dissection, and separation of stroma, donor preparation, and suturing. So trephination can be a manual using a handheld trefine or a suction trefine, which is much more predictable with less chances of perforation. And for optimal outcomes, reaching the Descemet's is desirable. There are various techniques of stromal separation which has been described. However, the fastest and easiest way to reach Descemet's is a big bubble technique described by Anwar. This is a typical big bubble which is circumscribed up to 8.5 millimeters in diameter, having a white edge, and it's usually obtained in KC patients without scar. And like it may not form in one go, we may have to inject air in several locations to obtain a proper big bubble. So after the big bubble is formed, I usually do a superficial lamellar keratectomy to debulk the cornea using a crescent blade and lymph forceps. And then I use a 11 number blade to make a nick incision to the central corneal stromal surface and enter into the bubble, inject visco to keep the Descemet's away from all the manipulations. Then with the help of a 1/2 scissor, you divide the rest of the corneal stroma into 4 quadrants or more number of segments, and each segment is then completely excised using 1/2 scissor, taking care not to leave any posterior lip. Viscoelastic substance is then completely washed out before proceeding to graft suturing. Coming to donor button preparation, I usually prepare it with the handheld define and using a Vexel sponge. The Descemet's endothelial complex is stripped off and then it is placed on the host bed and sutured using 10 monofilament nylon. Coming to the suturing, so I don't find any difference between interrupted and continuous suturing as far as astigmatism is concerned. So first it was fixed with 4 cardinal sutures. Getting a rhomboid configuration like this is definitely a useful guide. And finally 12 to 16 sutures depending on the size of the graft are placed and suture knots are buried under the host cornea. But you may not get these steps right all the time. Sometimes if you see here, it's a case of Dahlke. I have a nice big bubble now, but I'm doing a superficial lamellar keratectomy. I'm attempting a brave slash with the 11 number blade. I'm not able to collapse the bubble. So I just go ahead and do a second dissection and then debulk the stoma further. And now I'm able to collapse the bubble, and I continue with my regular technique of Dahlke. So I place 16 sutures in a graft if it is more than 8 millimeters. This is a case of Dahlke. I did not get a big bubble. This is a multiple bubble. There's emphysema of the cornea. I just go ahead and do a superficial lamellar keratectomy here and then inject air bubble again. I have a nice big bubble now. I'm trying to collapse the bubble. I'm not bold enough to collapse it. So again, I'm going ahead with the dissection. In such cases, if you are not bold enough to collapse it in the center, you can do it from the periphery. So go ahead and remove one more layer of stroma and then collapse the bubble. Now I have collapsed the bubble in the periphery so that it is safe. You can avoid complications of central perforation. Even if it is a small perforation in the periphery, it's easy to handle. Then you follow all the steps of Dahlke, complete it. Less than 8 millimeters, I usually use 12 sutures. Coming to the complications, perforation is the commonest complication. This is a case of granular dystrophy, very soft eye. While injecting air into the stroma, I injected into the anterior chamber, but you just change the direction of the needle and inject more air bubble into the stroma and do a manual dissection. So you can go layer by layer and reach pre-Descemet's. There's one more small perforation, but most of the dissection is over. So you can safely continue with the Dahlke and inject an air bubble into the anterior chamber to tamponade. However, larger perforations, it may be difficult. This is already, there is a micro perforation. I have injected air bubble into the anterior chamber. There is a large perforation here. And that is right in the center. In such cases, my dissection is also not complete. In such cases, it is better we convert it into penetrating keratoplasty. This can happen rarely. If you achieve a big bubble, most often you can do a DALK. But if you are going layer by layer, sometimes if you reach while reaching pre-desmites, you might perforate the desmites. And so it's an excellent procedure. It gives excellent results if you follow proper techniques carefully. Thank you very much.
Yeah, Dr. Shreesh, a wonderful presentation. A few questions are there. One, how do you, what's your rate of, big bubble getting in DALK?
It's almost 75 to 80% of the cases I get big bubble. That is type 1. And in scarred corneas, many of my cases I get type 2 or mixed bubble. And patients who have healed eye drops, I just inject air bubble away from the central perforated area. I go superficially, and that is mainly, it helps in the dissection. So even those with the healed eye drops, the results are good. If the eye drop scar is not in the center, if it is in the paracentral area, the results are good. I attempt DALK in these cases, and the results are good. So big bubble technique in almost 75 to 80% of my cases, the perforation rate is almost nil.
Well, any point from Dr. Vijay, Dr. Shakeen? They can shoot their questions to sir.
Initially, what I had when I was learning the DAL, the initial experience that I had was that you do everything well when you reach the desmites, and when you are removing the peripheral remaining those edges, and if you're using a say slightly sharper scissor ends, those ends can cause that perforation there. And it's very disheartening to see that happening at that point when you have done everything, all your hard work, and you have reached, you are sure that you have exposed the desmites almost completely, and you are trying to refine those peripheral edges. At that time, if you get a perforation, it's very disheartening. So I think one can be more careful and be more attentive at that places for the people who are learning new, who are learning DALK, basically the new ones.
Sricha?
Yeah.
I mean, you don't prefer paracentesis during this procedure.
No.
Can that?
Yeah, I have stopped doing it long back. I've been doing DALK for the last 13, 14 years, done more than 350 DALKs. And I have stopped injecting air bubble into the anterior chamber unless I have a perforation. And for a routine case of DALK, I don't do a paracentesis at all. So I had 2 cases of secondary glaucoma, pupillary block glaucoma, following which I stopped it, and it works very well in my hands.
Great.
Dr. Sati sir, you were doing those femto-assisted DALK. I remember that when we were doing it together, and I think they were giving very good results. Can you elaborate something on that at this point?
Yeah, we have been doing it femto-assisted DALK. Firstly, we should know up to which depth we call DALK. So there is a good paper on this from RPC only. So considering that depth, we started treating our patients with femto-assisted DALK. And what I have found that femto-assisted DALK equally works well. And, what we often think that there will be the edge disparity. And what I have found that over the months, this disparity also goes. That's second. And third, what we are scared of is popping out of, the tissue that we have grafted, which I have found even after doing phaco with normal parameters, they do not pop out. I have done 2 phacos in 2 such patients for past 2 months. So I have found that they do not pop out. So it's but we have done so far only 8 cases. Let's see. We will publish our results shortly once.
Dr. Alok, I have one question. Maybe you're doing a good number of femtodalk. Do you feel it has any advantage over the manual dalk, which we do? Initially, we also tried this femtodalk, but I didn't find much advantage of femtodalk because so you can't reach Descemet's with the femto, and you have to do a dissection to reach Descemet's. And there is an additional added cost to the patient. What is your opinion?
Yeah, very good question, actually. See, what prompted us to do this technique is when we found that a lot of patients are coming with, and most of these infections are suture related, especially in our setup. That's one that prompted us to do this. Second, regarding the depth, as per the VisuMax laser that we use at our setup, we can go up to 50 micron of tissue we can leave behind, and then we can easily go ahead. So normally we are doing pre-Descemet DAL, that's what we call. We have to leave behind 50 micron of stroma in that. And now the advantages over the normal DALK, which I have found, is one, if you look at the eye, it looks really nice. That's one. Second, there are no sutures related issues, which I have found. That's great because most of our infection and subsequent, even if you think the rejection is infections. So that's not there. Thirdly, what I have found is the astigmatism, I'm not getting great in these cases, and most of these cases, have to undergo subsequently cataract surgeries. So you can easily adjust the refractive astigmatism by putting a toric IL implant. So that's also an advantage which I have found in such cases. But it's too premature to comment totally, and let's see how it works. Thank you for your valuable suggestions, Doctor.
Thank you.
Yeah, please shoot the question. So I think we have very less number of speakers in this forum. Is Dr. Charuta is there? If Dr. Charuta, yeah. Good to see you, Charuta.
Likewise, how are you, Dr. Alok?
I'm very fine. And Dr. Charuta was my senior at LV Prasad Eye Institute. She is a prolific surgeon, I should say, and a lot of things we have learned from her during our fellowship program. She is also a wonderful teacher, and over the years, I have found that she has really excelled well in cornea and keratoplasties and other stuff. And one of her great work recently I was going through. So over to Dr. Charuta. Her topic is really very innovative, and that's the role of novel biomarkers and medical management in high-risk corneal transplants. Over to Dr. Charuta. Please carry on.
Good evening, good afternoon, everyone. Is my screen visible?
Yeah, you can put it in this big screen like in normal. Yeah. Now it's fine.
So I'm really happy to be here in this wonderful conference. So the topic for today is actually a very different one and something which we've been trying to pursue from the last 3 years. So traditionally, we think that corneal transplants work far better than other systemic organ transplants like kidney or heart or lungs, and that we believe very firmly that there is no role of HLA matching because of the presence of anterior chamber associated immune deviation. This is also based on the results of the CCTS group findings. Now, if we just look at the transplantation antigens, I'm sorry, this is just. Please give me a minute.
Yeah. Please take your time, Dr. Charud. Yeah, we are seeing your slides now. You can put it in the slide share mode. Yeah.
So, like I was saying, that we have a very firm belief that HLA is independent of ophthalmology corneal transplants. And HLA typically, our understanding is that it is a region which is present on chromosome 6 and is dependent on, is what we depend on for graft rejections in systemic grafts. Now, apart from this, they also have some role. Now, transplantation, they are called transplant antigens, and we know that those with preformed antibodies against HLA antigens are at high risk for hyperacute rejections, accelerated acute rejections, antibody-mediated delayed graft rejections, and also for long-term complications. Now, why are we so sure that HLA has no role? So we know from physiology that ocular immunobiology has given us anterior chamber associated immune deviation. So this immune privilege of the eye, of the cornea, is the absence of corneal lymph nodes and blood vessels. Also, induction of regulatory T cells by allograft inhibits induction and function of alloimmune T cells. It protects us from complement-mediated cytolysis. ACID also induces apoptosis of neutrophils and T cells at the graft-host junction. There is diminished corneal T cell proliferation owing to this ACID, and also diminished NK cell activation. Now, the immune privilege of the corneal allograft, to sum it up, is also present. That is, TGF beta is present in the anterior chamber. And antigen-loaded macrophages develop immunosuppressive characteristics. And the leakage of donor proteins into the anterior chamber will induce the anterior chamber deviation. Also, compact architecture of the corneal stroma itself inhibits infiltration of any immune cells. Blood aqueous barrier prevents immunologically active cells and factors from entering the ocular tissue. Now, when is this privilege lost? So, inflammation that is caused by the allograft can lead to a reversal of this privilege. Any other cause of inflammation or development of corneal vascularization, the ocular surface diseases such as SJS or OCP, or just presence of a loose suture for a long time where the patient doesn't access its removal, and a previously failed graft. So all these are situations where this privilege is lost. Now, what is the case against the role of HLA typing in corneal transplant? We saw all this evidence. Of course, the cornea is a very privileged organ. Also, the other case against it is that HLA matching is expensive, cumbersome, and the CCTS group has found that there is no actual benefit of HLA-A and HLA-B typing and matching. Now, what is the case for? So far we've been seeing on the side of the cornea. I'd like to say that we revisited the findings of the CCTS group, as have many other groups also, and found that lack of repeatability was there in the findings. Also, only 55% of the results actually had concordance with the original result, which means that when the samples were tested again later on to see the repeatability, only 55% actually agreed with the result, which means that probably 45% cases had a result that was not the correct one. So, and also the CCTA study group had followed an aggressive immunosuppression regimen. So, how can we assess role of HLA typing when an aggressive regimen is being followed? So these are the points against. Now, on similar lines, Vail et al. Have found that HLA-DR actually matching actually decreased graft survival. Bagusin et al. Found that HLA-DR could inhibit or obliterate the effect of APC on the initiating immune rejection. Also, case for HLA typing is that corticosteroids have a lot of side effects, including glaucoma, which is very dangerous. Now, so we are at two two ends of the scale. HLA matching can lead to reduced amount of immunosuppression, and aggressive use of immunosuppressive regimen overcomes the need for matching. So we are somewhere in between these two. Now, our current protocol is only topical steroids. We don't do HLA matching. Do we need to revise them? So with all this evidence in hand, I would like to introduce the concept of panel reactive antibody. It is a screening tool test for knowing a range of known unacceptable antigens that is present in the general population. Now, PRA is the amount of HLA antibody that is present in the recipient serum. So, if a patient with a higher level of PRA will potentially reject a greater proportion of transplants. And if the protocols that are being followed in kidney transplants, for example, is that if PRA is less than 50%, one could regraft only with mycophenolate and prednisolone. And whereas if it is more than 50%, that is the patient is more antigenically active, then we could have an induction regimen with basiliximab infusion, which is an immunoglobulin. Now, PRA is determined by was traditionally determined by testing 60 people. Then after that, we had a hybrid concept of calculated CPRA with a much larger number of organ donors, that is almost 12,000. So what about in ophthalmology? In ophthalmology also, this regimen has been made use of. It is called the Cincinnati protocol. And in any high-risk transplant, corneal transplants, such as because of ocular immune diseases such as SGS or OCP or other immune or high-risk grafts, they would do the baseline tests. In case of high PRA, would give an induction therapy. In case of and then monitor the levels and also give systemic tacrolimus. So now, what about in other, like I mentioned, in cases of kidney transplants, they also use PRA for allocation strategy. That is, those who are highly sensitized are considered as high risk and are higher up on the transplant list. So this is in summary what has been done. Now, what did we want to do was we wanted to look at the approach that ophthalmologists or cornea specialists in general have towards these concepts. So we created 3 cohorts for assessing whether we are ready for this paradigm shift. So we had 3 venues. One was the national presence of national cornea specialists at the Telangana Ophthalmic Society meeting in 2019. So we had 20 of them, and then 27 in the Japanese cornea seminar. Again, an international variety of corneal specialists, who were either junior consultants or even senior consultants were present. And the last cohort was a cohort of mixed residents such as nephrology, critical care, pulmonology, who were present for an academic session at my hospital. So these 3 cohorts, what we did was we presented these findings. That is, HLA matching has no role in corneal versus the role exists. We also explained the concept of calculated PRA and how it is measured. We also introduced the concept of PRA which is as it is existent in the current literature. And then we presented them after presenting them with the PowerPoint, we asked the cohort to answer a set of 5 questions. Now, very interesting to see that almost none of the national cornea specialists from the TOS conference were aware of the PRA test. Also, that if even after being presented the data, if cost was not a constraint, would they be willing to perform the PRA test? And also, if in a high-risk corneal transplant, with the given evidence that was presented, would they be willing to do the PRA? And so that showed that probably awareness regarding the points that were mentioned in this presentation as well was not there. As against this, we found a lot of openness amongst the non-ophthalmologists, and who were very convinced that probably corneal transplants required greater amount of panel reactive antibody testing. So this is my team. This is what I wanted to say today, and thank you so much, Dr. Alok. I would be curious to know your sentiments on this.
Yeah, Dr. Charuta, very well presentation, and I think you have given a very detailed overview. I have just a very small question to you, like what is the role of methylprednisolone nowadays in corneal allograft rejection cases?
So IV methylprednisolone we use in terms of acute graft rejection. So if the patient presents fortunately within the first 48 hours, then I use it as, this is my use of IV methylprednisolone.
What we remember, like what have been taught to us, like, methylprednisolone is basically to prevent the future graft rejection. Is it so? Or is it the current
yes, that is
graft
my
rejection?
So when we practice evidence-based medicine, then yes, that is the rule. That is the only rule actually, but it works only if it's in the first 48 hours.
Okay. So great, Dr. Charuta, for a wonderful presentation from your side.
Thank you so much.
Now
Thanks to all the organizers.
Now I invite Dr. Hitendra Ahuja to kindly present this part. Dr. Hitendra Ahuja is there?
Yes, I'm here. I'm just sharing my screen.
Yeah, sir. We'll be glad to have your presentation. His talk is on basically DSEC in unusual situations.
Good morning, and I am really sorry for this technical error, which turned this topic 360 degree. Actually, I had to speak on unusual situation in DSEC surgery. Is it okay?
Yeah, please carry on, Dr.
Okay. With the permission of chair, I would like to continue. And thank you, DOS, for having me.
Continue, sir.
We all know that Descemet stripping automated endothelial keratoplasty replaces deceased tissue with a thin donor graft of the posterior corneal stroma, Descemet membrane, and the endothelium. And the common indications for these procedures are Fuchs dystrophy, pseudophakic corneal edema, failed corneal graft, and iridocorneal endothelial. Choosing the patient, we have to be very careful about certain things, like if it's an early corneal edema, then the results are very good, and we should be very careful about elevated intraocular pressure, shallow anterior chamber, which can really give us trouble during the surgery, and presence of filtering bleb or the tube can really put us in. And the floppy iris syndrome or the aphakia, which can really lead to problems because of it can kind of destabilize the lenticule again and again because of the we are not able to provide the proper tamponade after inserting the lenticule. And if we talk about the key steps, the scraping of the epithelium, the incision should be scleral and 5 mm temporal, then marking with the Trefine is always better, so that we can score the inside the Trefine reference mark, and Trepine blue is an optional. Then there is no need, but if in case of uncertainty, it stains the testament, and we are able to complete the thing very nicely. And while stripping, the stromal injuries to be avoided, and no need to remove in failed penetrating keratoplasties, and the insertion can be by Teco technique injectors or the sheet glide. And while positioning the graft, we have to be very sure that there is no viscoelastic inside the anterior chamber, if at all we have used it, and we have to push a large air bubble inside for a certain amount of time, so that no issue of the dislocation post-operatively. And one more thing we have to remember is that once the graft is inside the eye, we suture the wound otherwise with the pressure of the AC maintainer or the pressure of the anterior chamber. The graft can escape out when we push the air bubble. So we at the graft dislocation, we all know, is a very common thing we face, and we can have an interface fluid also, which can lead to complete dislocation. But the good part is that the success rates of management are satisfactory. It is more than 70% as published and as seen also. And so I'll take this case one. He was a 68 years female who came to us with diminution of vision, pain, watering since few months. She had a history of cataract surgery done in the left eye 8 years back, and we diagnosed it to be having pseudophakic bullous keratopathy. We did a DSEC with a lenticule size of 8.5 millimeter, and 2 months post-operatively we saw mild interface haze. We went ahead and did a OCT. As you can see on the OCT, is very well attached in periphery, but the central, there is small gap and there's a little bit of debris here. But as such, the cornea looks compact, and the patient was doing symptomatically also good, and there was no problem with the vision also. He was having a vision of 612, and now it's been, I think, more than a year, and patient is doing good. And so basically we did not know what this entity is. We could not name it. We could not say that it's a graft dislocation also. And should we have intervened with patient having no problem 2 months post-operatively? And another situation, 81-year male who came to us with pain, redness, watering in the right eye, cataract surgery done 3 years back. Again, pseudophakic bullous keratopathy. We did a DSAC with a size, and this is the problem basically we faced when we started. No, we were not able to do that. Actually, there was no descent we could kind of remove, but we tried. But I think it must have kind of eaten up or gone. And but we still went ahead and pushed the lenticule. It got attached very well, and patient reasonably did well with no symptoms and a suboptimal vision, not that 6/9 kind of vision. But then this was another unusual situation we faced. And again, my third case, 65 years female who presented to us with again pain, redness, watering, diminution of vision. Since 3 to 4 months, again he had it was a failed graft actually. We went ahead and did the DSEC in August with the size of 8.5 mm. And on the first day when we did the OCT, it was a total detachment. It was not, the lenticle was not attached at all. And after rebubbling on the table, what happened was the graft shifted slightly and it kind of got stuck very nicely. And this was the post-operative thing that, as you can see superiorly, it's slightly displaced from the graft host. And now it's stuck very well to the posterior part of the original graft. So here I would like to draw attention of basically the sizing of the DSEC lenticule in the failed graft is very important. We have to be really careful about the graft function, because that's the edge and that disallows the lenticule to attach on the this problem of total graft dislocation post-operatively. Thank you, Dr. Alok. Over to you.
Yeah, Dr. Ahuja, it was a wonderful presentation and a lot of insight about the complications that we often face. Now, I think now it's my turn to go into the presentation.
Before that, can I just have 2 comments on first and second case, please, with permission of Chair?
Yeah, please go ahead.
In the first case, sir, was the graft prepared manually or was it prepared using a microkeratome? Because there was some irregularity on the stromal side of the graft, so which was making it a bit rugged. So either it was some interface debris or was it prepared manually?
Dr. Vijay, in all these cases, the graft was prepared manually.
Okay, so that actually we have also faced a similar situation. When we prepare manually, sometimes there are jagged edges over the graft onto the stroma side, so which can cause this type of case, and they do not oppose over a long period of time. It does happen, and but since graft at other places was opposed, so the cornea healed, cornea cleared very well in this case. I think these cases can be left like this. This is what is my experience with over a period of time, that these cases can be left like this if cornea is clear. Otherwise, if cornea is not clearing, there is some interface fluid which has gathered, it is not getting absorbed. So in those cases, we can go for a regraft, or initially we can try in early stages, we can try for rebubbling of anterior chamber. In the second case, now the ASOCT of the this post DSEC, the ASOCT is showing there is a scarring at on the host side, on the posterior stroma, there is a thick scarring. Now it could be a scarred Duas layer. The Descemet membrane and the endothelium complex might have got eaten, but there is a scarred Duas layer. It's quite localized, and if you see that clearly, it's very localized. And it's only the posterior, say 10 to 15 micron, and which is very hyperdense on the ASOCT. So we actually recently published one article where during a DSEC, we had to remove the scarred Duas layer, and then it got cleared. We just published it in a European journal. So that could be the cause for not clearing of that cornea in the second case. These were just the comments.
Thank you. Thanks a lot.
Yeah. Is Dr. Jagdeep is there? Dr. Jagdeep. Dr. Abhishek. So if none of them are there, so I can start my presentation.
Yes, sir. Go ahead, please.
Yeah. Good afternoon, everybody. The topic which I have been assigned is the repeat corneal transplantations. What are the indications? What are the outcomes and the risk factors for the repeat grafts? Now, why do we need a repeat keratoplasty? besides the graft-related complications, we all know that there is an increasing longevity of population with limited survival expectancy of these corneal grafts. And moreover, nowadays, newer surgical procedures are coming up. So that's also helping us in doing these repeat keratoplasty. Now, these are the well-known facts. If you look at repeat corneal transplants have a poor survival rate. We all know that as the transplant number increases, there is a successive survival rate, decreases. And what happened to all this? There is a huge implication on the patients. There is an implication on the eye bank resources because we are dealing with it. And of course, there is a huge implication on the surgeons because surgeons need to understand the benefit, the risk, the outcome of these. So considering this, we carry out a study at our center, not only in our center, basically this is the analysis of the number of repeat keratoplasty at 3 tertiary eye care setups, 3 tertiary eye care hospitals in our setup. And we analyzed the indications, outcome, and the risk factors for these repeat transplants. So we reviewed the medical records at 3 of our transplant centers, and it was a long period from 2012 to 2020. And we analyzed the demographic, clinical, and surgical data. And we maintain a 1-year post-operative follow-up protocol because, that's how we can assess the survivability of the graft. And the main outcome measures were visual acuity and the transplant survival. Beside this, we also collected data pertaining to demographics, original transplant indications, median time from prior keratoplasty to repeat keratoplasty, because there's a catch point here, and indications of repeat keratoplasty, number of repeat transplants, and what are the outcomes. So we did a proper statistical analysis as highlighted here. And the results, what we have got over this period, we, different centers, overall, they did 1,100 corneal transplants. And what we have found that 13.9% of them were repeat transplants. And ultimately, we took, 126 repeat transplants in this study, considering the exclusion criteria. So we found that 78% were male, and the median time of repeat transplant was around 57.2 years. Now, this was the original surgical techniques before the repeat transplant. If you look at 77.5% were penetrating keratoplasty, whereas just 15% was, the endothelial keratoplasty, and 7.5% were DAC. These were the original indications. If you look at in our setup, it is mainly the infective keratitis which has contributed to the great number of cases. Beside that, of course, corneal scar, which could either be post-traumatic, post-infective, with edema, and of course, the adherent leukoma. And if you see this original transplant indications, the keratoconus is just 5 of them. Now, if we compare, why I'm saying so, because if we compare the literature from the developed world, the keratoconus form the majority of cases in them. Whereas if you look at infection, it is very, very less. So this is the difference between our setup and the developed setup. Then for the original transplant indications for endothelial keratoplasty were basically the PBK. For DALK, it was corneal scar. Now look at here, it's very important if you look at the median time from prior keratoplasty to repeat keratoplasty in our setup is about 1.24 years. Now this is much less as compared to the developed world, where it is about 6.12 years. So this gives us a thought process to think why it is so. So when we analyzed in our setup, barring, whatever race you call or the dark race you call, more chances of allo rejection, but what we have found, it is the follow-up, and especially in our setup where everything is free, people don't care for free. And that's why they do not come for the regular follow-up. They do not take medicines regularly. And that's why the allograft rejection, infection, and other things happen. And I think that's what I have analyzed over the years. This is the main issue in our set. Now, the indications of repeat keratoplasty. If you see, it is basically the endothelial decompensation with history of rejection. This is the most common. And this, without history of rejection, if you look at, this makes the big chunk of the indication of repeat keratoplasty. And I think it is lined with the literature which is available from the developed world. Now, regarding the donor tissue, the median age, whatever data I could gather, because I have the limitation of this data being a retrospective study, and the data at times is not 100% accurate, not available. Of course, we all know that these are the limitations of the retrospective study. So the median age, which I could gather, is 63 years, and the median donor endothelial density is around 2549. The comorbidities is, what I could found is glaucoma in 11 eyes. It could be even more. And, TRAB were done in 3 eyes, and the more than 2 quadrants of vascularization was seen in 13 eyes. Now, these were the repeat corneal transplants. Now, if you look at, it's almost half-half. Half PK, half endothelial keratoplasty. Now, if you look into the developed nation, this is from New Zealand, this article, latest publication regarding this, you can easily see that PK amounts to majority of them. Endothelial keratoplasty, it's nowhere before PK. So here we can say that, okay, we are ahead of them. We are having more expertise. We are getting gradually more and more expertise on endothelial keratoplasty. So it may not be valid from a study from USA or from UK, but you can't avoid New Zealand too. Now let's go to the outcome. If you see the visual acuity, 1.77, if you see in logMAR, it comes out around, it's about 1/60. So VCV at 1 year is what we have achieved is around 618 to 624, and at 2 years between 612 to 618. That's what we have gained. And if you look at EK, it's almost similar. So when we analyzed, statistically, we didn't find significant difference in visual acuity between these 2 procedures, though the trend was more in favor of EK. We could find corneal allograft rejections in 9 eyes. 2 eyes experienced more than 2 episodes of graft rejection. This is, I'm talking about those who have undergone repeat grafts. And raised intraocular pressure was documented in 21 eyes, infection 7, and graft adhesions 2 eyes. Now, regraft survival, assessing 5 years is very difficult in our setup because we do not stay at one place for more than 4 years. But whatever I could make out from whatever data I could get, at 3 years plus 69.5% cases only survived in PK, whereas 88.67 in EK. So, but I could make out that there's a trend of better graft survival in EK in our setup, but it is quite variable. And the risk factors for the regraft failure is almost similar what has been described in literature, nothing great in this. So if you look at the proportion of regraft, it's almost similar to the United States. And the most common indication of regraft, if you look at in our setup, is allograft rejection, whereas in developed, keratoconus is the most common cause. Now you can say how? Because, invariably those grafts were happening in early age. So by the time, there is a specific graft survival for every graft. So that could be the reason. The type of repeat grafts which we have is much, it's almost 50-50 I told, but if we compared with a developed nation like New Zealand, it's, you can see. So here definitely we are ahead of them. And the visual outcome in our study, if we compare between PK and EK at 1 and 2 years, we couldn't find any difference, whereas the same is there as per Australian Graft Registry and of course by Wong et al. Now regarding the graft survival, though our study has not specifically told statistically the graft survival because we have to make the Kaplan-Meier analysis chart, which we couldn't because our statistician wanted more data. So, but what we have found that there is a trend is in favor of EK. in our. Whereas in Australian graft registry, if you look at, it's superior for repeat PK for keratoconus and TBK, because you see the indication. Indication is basic to the keratoconus, where you can expect the, much better graft survival. Whereas a study from Singapore Eye Institute has clearly stated that repeat PK has poorer survival as compared to doing EK after PK. So it is almost in line with our study. So we believe that there are reasons of repeat graft seems to be multifactorial and do not just explained by the allograft rejection. What's more important in our setup is treatment adherence, which is very, very lacking. Of course, socioeconomic status also makes a lot of difference. And especially in our setup, I have found that the serving soldiers behave much better than non-serving soldiers, maybe because they are more adhered to the treatment. And of course, the systemic health also makes a lot of difference in this. So what we need today is that we need a more tailored treatment, including culturally appropriate, coordinated post-operative supervision, and the long-term topical steroid. And of course, please give immunosuppression wherever you find a repeat graft, because I have found, though I have not done the study, but I have found the outcome is coming better. And of course, we need a robust corneal transplant registry in this country. It's not only, the registry we make where we are just telling, okay, this is the indication and, this is one when we are doing. Even the follow-up protocol has to be strictly adhered in that registry, and there should be a reminder system, because after all, we are not doing, grafts in lakhs in this country. So we can very well do that. So these are some of the photographs I would like to share, the repeat DSEC and repeat EK. And thank you for a patient here. Yeah, any comments from?
Thank you, sir. I think that's a wonderful overview, and it's very important to do this type of study to actually know how our
Very
graft
wonderful study, sir.
Very, very important. Very important, and I think it gives it immediately after surgery. The graft may look very good, but after 6 months, 1 year, once we do this type of study, then we come to know that what actually our results are. So, a wonderful study.
Wonderful, Dr. Alok.
Thank you, Dr. Chirag.
It's very interesting, don't you think, that keratoconus patients, I think primary indication is very less in our study versus the West. Maybe people don't want to come back, or actually, of course, incidence is less, but really very interesting findings. Wonderful. Congratulations.
Thank you. So is Dr. Abhishek is there? Dr. Jagdeep?
Abhishek.
So if none of them are there, I think we have finished our session.
I think he was busy with the OT. We are not.
Oh, doesn't matter. So now I request Chairperson, Dr. Shakeen Singh, to say the few words before concluding the session.
It was really a very wonderful interactive session and a very interesting study from Dr. Vijay K. Sharma. And of course, this other study was role of novel biomarkers, which would carry a long way, help in the corneal transplants. And I would request Dr. Alok if we can collaborate at the state level rejections, and if we have some process of monitoring these rejections at the different levels. Like you have told me about the registry, I think that's definitely required to monitor the kind of transplants and the indications of rejection and the protocols for post-operative that should be uniform all across.
True, very true.
And it was really a very wonderful and educative study. That's what I have to say.
Okay.
Any comment from Dr. Vijay?
Sir, I think that's the point about registry is very, very
Dr. Charuta?
It was wonderful to be part of this session, and I think we had a very nice variety of cases also. DALF, DSEX, Peters anomaly, wonderful.
Dr. Hitendra.
Thank you. Thank you for having me. Thank you. Thanks a lot.
Okay.
That was a wonderful session.
So with this, we are concluding this session. Okay. Goodbye, everybody.
Thank you.
Thank you.
Thank you.
हा मग थांबून
बस बच्चे ने भी सब देखा
अरे आंटी जाने चल चल
काय त्याला આગલું સ્ટેશન વહેલું પતું
અમાર તો પૈતું જ અને છે ને ડોક્ટર ગોયલનો બહુ જ ત્રાસ છે
ગોયલ
પીએસ ગોયલ પહેલા 3 ડ્રોપમાં એટલું જરી કાઢે છે પહેલા
How are you? Unmute.
Good morning, sir.
Good morning. How are you?
Fine, sir.
You are busy with your conference now.
Yeah, actually, I had talk in 9 to 10:30 session. I completed and now I'm going for basic. So he said that just have a cup of tea and then go.
Okay, that's good. Otherwise, everything is fine.
Yes. We had a pediatric ophthalmology conference
I know.
and we had 590 registrations.
Very good number. It will increase to another 100 more. And in virtual platform, maybe it is more also.
Yeah. Good.
Otherwise,
Good morning, sir.
Good morning, Prashant.
Good morning.
Prashant.
Morning,
Good morning, Prashant. Prashant, there are a lot of follow-ups.
बोलिए सर.
अरे यार पैसा दो उसको साई को एक तो.
अरे वो अभी ये संजू आएगा, मैं उसी की राह देख रहा हूँ कि उससे पहले अपने
दूसरा वो सारे सर्टिफिकेट और प्राइजेस के लिए मुझे फॉलो अप कर रहे हैं. पैसा हमारे अकाउंट में आ गया है.
सबको मालूम है शाह साहब के पास ही पैसा होता है इंडिया में आजकल.
हमारे पास कोई पैसा नहीं है. पैसा OTSI के अकाउंट में आ गया है. तो आई थिंक वी नीड टू पे नाउ.
सर संजू हैज प्रॉमिस में, मैं आपको व्हाट्सएप दिखाऊंगा. अभी आने दो, उससे का फिर हिसाब लेते हैं कि
तो साई अभी आके हमारा काम करने का ना बोल रहा है. ही इज रिफ्यूजिंग.
नहीं, मैं अभी बात करता हूँ उससे. अभी बात करता हूँ. कल मेरी डॉस में एक क्विज भी है, तो आई वुड बी स्पीकिंग टू हिम. डोंट वरी सर. उसका आपका कौन सा काम है अभी? आपका पॉसी कैसा रहा सर?
वेरी गुड है.
हाँ, अरे वाह,
पॉजिटिव बहुत बढ़िया रहा. It was 590, you know that. 590 registration other than YouTube and Facebook.
Wow, great.
It was very good. Hi
Hello.
Gunjan, how are you?
I'm good, ma'am. How are you?
Fine.
Hello, sir. Good morning.
Hello.
I'll take everybody's leave. I have to go for OT. Thank you so much.
Sir, you all are like.
Trauma people are all free people. Don't have to go to any theater.
Yeah, one more minute. But what are the other speakers? First speaker is here.
जी सर बोलिए.
कैसे हो?
फिनिश थिएटर.
एकदम बढ़िया सर.
फिनिश
आज का
थिएटर.
ये प्रोग्राम 1:30 बजे का. हाँ जी सर.
थिएटर खत्म कर दिया क्या?
नहीं, ओपीडी ड्रेस है सर. ये ओटी 3 बजे है.
हाँ, हम तो ओपीडी सुबह 6 बजे से खत्म कर दिया है.
बाप रे. नहीं, ये प्रोग्राम आज 1:30 बजे का मुझे पहले अर्लियर कम्युनिकेशन था.
नहीं 12 बजे का ही था.
बराबर 12 बजे का टाइम दिया है.
मुझे नम्रता शर्मा ने जो मेल भेजा था मैडम ने, उसमें ये लिखा था 1:30 to 3, इसलिए मैं तो उसी इसमें था. और 1:30 to 3 में मेरा एक टॉक भी है, तो सब अभी गड़बड़ हो गया.
Mehul?
हाँ सर.
First speaker has come or not?
क्या?
If the first speaker has come, we can start or we can take the second speaker. Because time.
I think there are 2 speakers are there now.
There are 2 speakers I can see. One is Gunjan, other is.
So Dr. Dinesh is not there.
It's exactly 12 o'clock now.
Dr. Piyush is there.
Yes, sir.
You can start now.
Sir, you initiate the proceedings. Welcome वगैरह कर दीजिए. Our moderator Sanju is not.
Timer तो नहीं दिया ना अभी तक.
Hello.
The timer.
So, I think I will initiate the proceedings, sir.
Okay, you initiate the proceedings. Just give the introduction and then start.
Good morning, everyone. Yeah, good morning, everyone. Welcome on behalf of Delhi Ophthalmological Society to this session on behalf of Ocular Trauma Society of India. We have our president, Dr. Mukherjee, who will be chairing the session. Co-chairman is Dr. Ashok Grover, sir. Convener is Dr. Mehul Shah, and moderator is Sanju Mohan. So now we have just, it's exactly 12 o'clock. Without any further delay, we begin our course now. The first talk is by Dr. Dinesh Garg in his absence here. I think I will request Dr. Piyush Patil, who is with us, who has already joined us, who would be speaking on IOL implantation in the presence of pre-existing anterior and posterior capsular tear in cases of traumatic cataract. Over to you, Piyush. You can share your screen.
Can I request the admin to start the timer?
It has to be 7 minutes precisely.
Is my screen visible, sir?
Yeah, make it full screen.
Yeah. First of all, I would like to thank Dr. Mukherjee sir, Dr. Prashant Bawankoe sir, and Dr. Mehul Shah for giving me this opportunity to present at such a wonderful conference. I'm Dr. Piyush Patil. I am a cataract and refractive surgeon practicing at Datta Netralaya, Yavatmal. I'll be presenting two cases today. Mainly IOL implantation in cases of pre-existing anterior and posterior capsular tear. These both are traumatic cataract cases. I'm starting the first case. This is a pre-op slit lamp video. The anterior capsule is already disrupted. He got a trauma by a thorn. So when we opened the anterior chamber, lens matter popped out. And this was the situation of the anterior capsule after staining. It was like an Argentinian flag sign. It was a pre-existing. We just made 2 side ports. We did not make a main incision as yet. It was all mainly soft cortical material, which is being aspirated with the I&A. I made a 3rd side port to better gain access to this temporal area. So after this aspiration, I noted that there is a tear. Is my arrow visible? I'm just pointing to the posterior capsular pre-existing tear.
Yes.
So, but the anterior hyaloid was not disrupted. So I took a decision. I gave a nick in the anterior capsule. I made it somewhat round, though it was like an Argentine flag sign. I had to make some space for my one-piece IOL. I had selected a one-piece IOL because the anterior hyaloid was not disturbed, and I thought I can easily implant this one-piece IOL in the bag. Hydrophobic single-piece IOL. Now it is more clear. The rent is more clear now. This is the pre-existing posterior capsular rent. I injected some dispersive viscoelastic out there. This is that one piece, single piece hydrophobic intraocular lens. So one side port, I'm using a Sinskey, I'm using a Kuglen hook, and we are putting the haptics in the bag now. So haptics and optic both in the bag, and the rent is the same size. We have not extended the rent. Without disturbing the posterior capsular rent, we have implanted the IOL. Routine I&A is done, taking care that the AC does not become too shallow or very deep. Water light is kept to a medium level. Whenever we come out of the anterior chamber, we use a hydro cannula to push fluid into the AC. I'm staining it with Oroquat to see if there are any vitreous stacks, and to my surprise, there was some vitreous stack, which I had not thought of. So we are doing a limited anterior vitrectomy with a irrigation handle in my left hand and this vitrector in my right hand. With the same vitrector, now you'll see me doing a PI. The wounds are hydrated and the surgery is done. There is a post-op small video after this. Then I'll be showing another case. So this is the post-op picture. You can see this is the first day post-op picture. First day. This is the PI, clear cornea, and to all surprises, the patient had unaided 6/6 vision. We did the biometry, corneal keratometry, everything from the other eye. and still the patient turned out to be immetropic first day. You can see the patent PI also. I'm going to share another case now. Prashant Dada, I am audible?
Yeah, you are well audible. Go ahead. Make it fast. You have to make it in 7 minutes.
Yes, sir, I'll complete in 7 minutes. This is the second case. The lens matter was already in AC when the patient presented to me. After control of inflammation, in 2 days, we took the patient to the OT. This was the entry site where the iris was incarcerated in the wound. So this is the dilated picture. So we took up this case. Again, we are not fashioning the main port as yet. I'm staining the capsule. You can see the capsular fibrosis. Just in 2 days, this is the intercapsule fibrosis. Very careful I&A has to be done, because sometimes the intercapsular margin is not very well visible and it gets irregularly stained with trypan blue. So very careful I&A needs to be done. Lens material is obviously very soft. These both patients were around 25 years of age, very young patients. Here I'm switching hands, but before removing the irrigation cannula, we are injecting dispersive viscoelastic. We don't want the antechamber to shallow. No sudden shallowing, no sudden deepening. So here also I'll show the rent. This is that pre-existing posterior capsular rent. Oval shaped. Very well visible now, this one. So we gave a nick in the entry capsule, made it somewhat round. I had edited that portion where I checked with the Kugelan and Y hook that the intercapsular extension was not up to the posterior capsule and it was limited to the zonules. I injected some dispersive OVD through that rent to plug that hole. We are injecting a one-piece IOL here, single-piece IOL here. With 2 instruments. Now this haptic has gone into the sulcus. I am again repositioning it. Now it's in the bag. Injecting some pilocarpine here to bring down the pupil. Injection of some tricot just to see if there is any vitreous like in the last case, but there was none in this case. So no vitrectomy needed. This is the immediate first day post-op picture. You can see a clear cornea, a quiet eye, and the patient had an unaided vision of 20/25 on the first post-op. Thank you so much.
Piyush, I have one question to ask you, or rather observation.
Yes, sir.
In your first case, the
Yes, sir.
wound of, in your first case, the wound of entry was quite peripheral.
Yes, sir.
And how big was the thorn that could produce the cataract? Because there is no hole in the iris. As in the second case, you could see the hole in the iris also. But in this first case, there is no trauma to the iris. And in undilated pupil, you could see the iris is absolutely normal there. So how big was that thorn that could produce the cataract?
Sir, I have not seen that thorn or that needle in the second case. The patient has told me that he was visiting his farm and a thorn of a tree that went obliquely. That is what he told me. I have no sufficient evidence.
Yeah, unless it goes obliquely, it is unlikely to produce cataract without making a hole in the iris. Quite right.
Yeah, maybe it went through the center, sir. I don't know. Maybe it went through the center of the pupil. I don't know, sir, how it went obliquely from like this or.
But your room shows at the peripheral part. That's
Yes,
why
sir. Yes.
that was
Yes.
I think, can I make a comment here, sir? Piyush, I will request Dr. Dinesh Garg, you have to stop. Dr. Dinesh Garg is the speaker who has joined us now. Meanwhile, till he shares his screen, Dr. Dinesh Garg, I have a question for Dr. Piyush Patel. Dinesh, you can share your screen. Piyush, it's a vegetative injury.
Yes, sir, please.
So
Yes, sir.
thorn injuries can carry a of infection inside the eye. So what do you think about putting a lens in an eye which is having a potential infection and another foreign body inside the eye? You have to take it.
Yes, sir. I will tell you that.
I can comment for the same.
Sir, sorry, can I speak?
Yeah, please.
Yes, sir. We took the patient, that thorn wala patient, we took him after almost 15 days. In the second case, it was with a needle. We took it in 2 days. So we controlled the infection first. We gave him all the antifungals, systemic, oral, topical. We controlled the infection. Then we took up the patient, sir. And I was absolutely quiet when I took him for OT. And post-operatively, we kept a close watch. So
okay, I'll have a small comment. Prashant, am I audible?
Yeah.
Yes, please.
Yeah.
Yes, sir.
When it is a thorn,
yes, sir.
majority
Yes, sir.
of thorns in our country are the bubble thorn.
Yes, sir.
The biological name is Elosia nilotica, and we found many references, and we have published the article regarding this strain has got biological material which is preventing antifungal as well as antibacterial properties. And out of, I think we have series of more than 1,000 cases, only 0.3% patient had an infection. And this is very classical penetrating injury. The type of cataract what you have shown are not present in the globe rupture or in perforating injuries. Right? These are only penetrating injury always gives a better visual outcome. And infection, though it is said vegetative, it is against the traditional thinking, but we don't find any infection in these cases.
Okay. Yes, thank you, Dr. Mehul, sir. Thank you, Piyush, for a wonderful case. Now over to Dr. Dinesh Garg for his pole-to-pole surgery in ocular trauma followed by secondary PCI. Dinesh, over to you.
Thank you, sir. Thanks, DOS, and thanks to the chairpersons, Dr. Mukherjee, Dr. Mehul, Dr. Grover, and Dr. Prashant Bavankulle for this opportunity. I am presenting today one of my cases where I did a pole-to-pole surgery in a case of ocular trauma, and 2 months later we did a secondary PCIOL for him. I have no financial disclosures to make. This was a 17-year-old male with injury to the right eye while working. He had a visual acuity of 2/60. We did corneal tear repair with PPL, PPV, with removal of foreign body, cryo, and silicone oil in the first sitting. And later on, we did silicone oil removal with secondary BCIOL. So few steps we improvised to make it possible to put a in the bag IUL for this patient. So this is how the first surgery was. I would just say that it was a skill, art, as well as a lot of luck. So these are two side entries which we have made, and then with 10-0 proline, we stitched the corneal wound. So here, I think the careful planning was important. We have put 23-gauge cannula, and the interior capsular opening was fashioned in such a way that it was converted into a interior.
Can you reduce the volume? Can you reduce the volume of the music? We can't hear you.
Is it better now, sir?
Bring it down further. Music is too loud. We can't hear you.
Is it better?
Yes.
Yeah, better.
Now?
Yeah.
I've stopped the music. So we did IA and then proceeded with the pars plana vitrectomy. And here also, with the help of a cutter involving the posterior capsular opening, I made it out into a posterior CCC. So these two openings will help us later on put a lens into the bag. And then anterior vitrectomy, posterior vitrectomy, we localized the foreign body. We removed the vitreous around that along with vitreous hemorrhage. Then I picked up the foreign body with the help of a intraocular magnet. It was embedded there, and I had to pull it out a little bit. And then very carefully, I moved it anteriorly and removed through the limbus, making sure that none of these openings get torn. So this was the foreign body, followed by vitrectomy with induction of PVD, triamcinolone assisted, and then FGE and cryo to the site. I'm sorry, I think it has stopped. So at the end, we left the eye with the silicone oil, and the retina was attached at 2 months, and we decided to remove silicone oil with a 25-gauge pars plana sleeve. Silicone oil was removed through the limbus, and after that, these two openings were separated because they had fused. I used the iris repositor as well as this micro forceps to remove all the adhesions between the two capsules. And then Aquarius lens with the 4 haptics. This was put into the posterior chamber and then dialed into the bag, into the openings of these two anterior as well as posterior capsular openings. So this is how it went right into the bag. This is a hydrophilic IUL, and it's rather more flexible compared to hydrophobics, and there is no posterior capsule, so there is no chance of any PCO formation later on. So this is the end of the surgery, and 2 years follow-up is what we have, and he had a best corrected visual acuity of 6.9 with just plus 0.75 cylinder at 20, and of course he needed an addition. There was a small central corneal opacity with the quiet AC. Intraocular pressure was normal, and the intraocular lens was well centered. So this is the fundus picture and OCT at 2 years follow-up, and this is a great result from my side, and that's what I wanted to present, and the little improvisations which we did. Thanks a lot, sir. Thank you. Thank you for your patience.
Wonderful case, sir.
Thank you.
Beautiful.
Thank you,
Dr. Dinesh, it was a great case.
Thanks a lot.
Yeah, and comprehensive management.
Thanks a lot, sir. Thank you.
Excellent presentation, Dr. Dinesh. Really enjoyed it, and very good results. Would you tell us something about the pros and cons of putting an intraocular lens in at primary surgery when you are doing a VR surgery as well, and you are putting in a silicone oil? Would you tell us the pros and cons of doing a intraocular lens at the same sitting?
So normally, if I have to put a tamponade, either gas or silicone oil, I don't put a primary intraocular lens implantation at that stage, especially when the PC is already ruptured. So in case there is
even though you were able to convert it into a controlled rhexis.
Yes, sir. Yes, sir. Even after that, because you don't know how the things are going to behave. There are some zonular weaknesses also. The oil may come into the anterior chamber, but this is usually left for a secondary implantation. And especially if we put gas, then prone positioning can lead to a lot of issues. Even if we put a PCIUL in a silicone-filled eye, then there are a lot of deposits at the posterior surface of the lens. So I usually avoid putting a primary IUL in these situations. If the PC is intact, of course, that can become a choice. Like if it is a scleral tear and you are able to do that, but usually in those cases, the cataract is not much. The cataract gets formed only after like silicone oil or gas has been there in the cavity.
Can
so
I
Yes, Prashant, your views on this?
The thing is, sir, these eyes which need vitreous surgery do react violently post-operatively, and then can give us a media problem and challenges, and can have a depositions, as already Dr. Dinesh has shared about it. But in such a localized trauma where you have a small foreign body causing a small tear, I would have gone for, after removing the IOL, I would have gone for a primary IOL implantation in this case, along with whatever be the tamponade. Usually a small foreign body impacted would need a simple gas, and gas, if you put it in the bag with such a beautiful controlled rhexis, which Dinesh could achieve, in the bag would have been possible. Even in the sulcus would not have made much of a difference that you have, but you need to remember that you should create a PI definitely in all these cases. So that in case there is a block because of an oil or a pupillary block because of an oil or a gas, that can be tackled. So that's what my take would be in this cases.
Only the biometry may be a little difficult with a fresh corneal wound. You may not end up as accurate with a open cornea. And
biometric control we can take from other eye, but with my silicone oil inside, the lens will go hypermetropic side, and when I remove again, the patient will turn out to be myopic. So accurate biometry will be difficult in primary implant.
True.
With this like silicone oil in the eye, we usually use IUL master, which gives very good IUL
with the correction formula available there.
Yes, sir. Yes. For that particular silicone oil in the eye, it will be all right, accurate. But when you remove the oil, then patient will
No,
turn
sir,
out
no.
to be myopic.
Mehul sir, for such cases where you put a silicone oil tamponade, we warn the patient very clearly that he would have a need of glasses, hypermetropic glasses initially till we do a silicone oil removal. And we should aim for a biometry or a lens power that is going to be post SOR. So that will help us in reaching out a emmetropic status to a lot extent.
Thank you. I think we can go to the next presentation.
I think.
Thanks a lot, sir. Thank you.
Okay. I think we should, so I think I see Dr. There it is. Hello. Hello.
Yeah.
Hello.
Dr. Shalu. She is there, no?
Yeah, Dr. Shalu.
Yes, sir.
Please do join the screen. Please share your screen. Yep.
You have 7 minutes for presentation. Keep time.
Is my screen visible?
Yes.
Yes.
Good morning, everyone. I'll be discussing about some of the eyelid and lacrimal trauma which we usually encounter and is seen because of the commonly encountered due to the blunt and the penetrating injury we see in our practice. These injuries are usually associated with multi-system involvement. So when the patient we see in the emergency, we have to establish ABC. And then before going for a local examination, it's important we should rule out globe injury because inordinate pressure may cause more damage in these eyes. The detailed history is very important to know the nature and mechanism of injury. And we should note the detailed medical history as well as the drug history if we are planning to take the patient for surgery. A few words about the dog bite injury, which we know is known to cause infection. So we need to put them under antibiotic. And if we are planning for surgery, we need to irrigate the area copiously with saline and povidone iodine. And before taking the patient, we have to inject immunoglobulin around the wound and give prophylactic vaccine as well. So the word of is that we can go ahead with the primary repair in dog bite injury, but taking a particular steps before we take the patient for surgical management. CT scan is the modality of choice. However, in case where we need to see the soft tissue and optic nerve, and if we have ruled out the metallic foreign body, we can go ahead with the MRI also to assess the optic nerve injury. Coming to the local examination, it's important we should note down the location, whether it's a superficial or deep injury involving the margin of eyelid, or it's a non-marginal injury involving it's a preseptal or postseptal. Are there any presence of foreign bodies, whether the tissue loss is there, and involvement of canthal tendon, and we should rule out the canalicular injury in these cases. The goal of this repair is to re-establish the anatomical configuration, to restore physiological function, and to improve cosmesis. For all this, one should be well versed with the anatomical landmarks and should follow these landmarks when we are carrying out the surgery. Medical legal documentation and the photographic documentation is very necessary and nowadays. And the timing of surgery depends. The primary repair can be done within 2 to 4, within 1 or 2 days. However, if there is a lot of, we are suspecting infection or there is edema, then we can delay the surgery for 3 to 4 days. However, secondary wound repair should be done after the 6 months. So the general principle need to be followed with cleaning of the wound, remove the foreign bodies from the wound, trim the ragged or devitalized tissue. However, it should be done minimal as face has a rich vascular supply. Align all the tissues in the normal anatomical plane and close them in layers to achieve the better outcome. This is a small video showing the basic principle of full thickness eyelid marginal repair. Carrying out the basic principle of 3 mm from the cut end and coming out from the same depth and coming back at 1 mm and entering the other cut end. Then the suture is tightened so that there is a slight pouting of the eyelid margin. The first suture is passed at the gray line, and then other one at the posterior limb margin, and then at the anterior lash line margin. So 3 sutures are passed, and we can use a 6-0 silk or 6-0 nylon depending on the surgeon's choice. Then the sutures are tightened and brought in front so that they don't rub the ocular surface. The tarsals can be sutured with fiber vicryl suture, and then the silk is sutured with a silk or nylon suture. This is the illustration showing the pre and the post-op repair. If we see the fat prolapsing in the wound, then we should suspect the levator injury, and they should be repaired end-to-end with the fiber vicryl suture so that we can prevent the sequelae of later on. This is an illustration showing a vertical laceration in the lid is split in 2 halves, and then the multiple layered closure is done to achieve the results. This is the post-op picture showing a slight improvement, and the lid is started opening up. In case we are suspecting tissue loss, we should see sometimes these are retracted tissues, so we should place them in anatomical position, and when sometimes we can align them. However, if there is a tissue loss, we should follow the basic principle of reconstruction to have a good outcome. This is an illustration showing the traumatic medial cancer eversion and the skin defect, and using an advancement skin flap to close the lid. This is the end of the surgery. The same one example of the tissue loss, and the tarsal rotational flap was used, and the anterior lamella was repaired with the skin grafting. In the lady with the multiple lacerations, the end-to-end suturing was done. However, the defect was left in the upper lid, and if we suture them end-to-end, it may cause ectropion later on. So the skin graft was used in this case. Canthal tendon injury should be looked upon whenever we're seeing there's a loss of contour on the medial canthal or the acute angle of the lateral canthal, and can be assessed by pulling the lid towards the limbus. Medial canthal injuries are usually associated with canalicular injury, and the repair of posterior crus of medial canthal tendon is critical, and it should be sutured with a foroproline suture to the periosteum at the level of the posterior lacrimal crest. However, in most of the trauma, we may not find the periosteum, then we have to do the microplating or go for transnasal wiring. The similar principle is followed for the, this is an illustration showing the medial canthal repair. So the similar procedure showing the lateral, similar principle should be followed for the lateral canthal injury repair. And the tarsal is sutured at the periosteum at the level of the lateral. Or then if the periosteum are not available, then we may have to drill holes and pass suture through it. This is a child with a lateral canthal eversion, and then this is the post-op picture showing after the repair. The canalicular laceration, they can be occult or obvious, and so one should always suspect them if we have a medial canthal injury and should look upon them. The early repair is preferred, however, in a day or 2, but it is possible to negotiate the medial cut and also within 5 days of injury. So the basic principle is to identify the cut end. The medial cut end is crucial, and it can be identified if we place them in a normal anatomical position under the microscope and a good illumination we can usually identify. However, if it's not possible, we can inject the saline or from the opposite punctum in or air from the pool of fluid, and then we can identify this. We can see a pearly white medial cut end, and sometimes the surgeons prefer the use of pigtail probe. So the basic principle is identification and then approximating the edges by passing the stent. So the mini Manoka stent is most commonly used, and it is, if not available, we can use the intracath cannula, which is easily available in our OTs. In case of bicanalicular injury, we can use the bicanalicular stents. After passing the stent, the pericanalicular suturing is done with the 8-0 nylon suture. This small video showing the same patient with the vertical cut end, and then after passing through the probe, we are identifying the cut end. We can see the medial cut end here. Because the tissue was retracted, so we passed the 5 ovicral sutures through the orbicularis so that the lid can be brought closer, and it helps in passing the mini Manoka stent. So the stent is passed. Sometimes we may need to bevel the cut end, and then it helps in facilitating the passing of the stent to the both cut ends. Then after passing the stent, the pericanalicular suturing was done with 8-on vicryl suture, and then the margin can be repaired as described earlier. This is a patient with the avulsed medial canthal with canalicular injury, and this is the post-op picture. Another patient with the medial and lateral canthal avulsion and the canalicular reapposition was done with the canthal fixation. So in these cases, we should be well versed with the anatomical landmark, and if properly done, we can avoid the sequelae in this case and can achieve the successful cosmetic and functional outcomes. Thank you.
Wonderful presentation. I think Dr. Shalu has covered all aspects very, very well of laceration, including what is important to assess is try and do a primary repair as far as possible, because that affords you the best opportunity to get back the anatomical and functional results and the best possible cosmetic results. And if you have the opportunity, doing a good marginal apposition is, I think, the most important part of it. And secondly, making sure that you take care of the medial canthal and lateral canthal injuries. And if, of course, you have fat prolapsing, you know that there is possibly an injury to the levator, and that should also be taken care of. Canalicular injury part, I think she covered very well and showed us how to identify the medial cut end, which is the key, and then maintaining the patency by some kind of a stenting, which is intubation. And now we know that a stenting for a period of about 4 to 6 weeks is more than enough, and you don't need any longer stenting. I think all aspects have been covered very well.
Very nice presentation.
Thank you. Thank you, sir.
Can you pass on to the next one, Pradhan?
Yes, sir. Hello.
Dr. Purendra wants to present early because remaining people are not.
I think there are other people are also waiting. Someone has to go to the other hall. So it is up to the person to manage the thing, because Gunjan is waiting for a long time.
Okay, Dr. Gunjan, are you there with us? You can start sharing your screen, and she's going to speak on a stitch in time saves 9. Dr. Gunjan, please share your screen.
Is it visible?
We can't see.
The screen is not visible.
Is it visible, sir?
Yeah,
Hello.
Not yet.
Good afternoon.
Yeah, now.
Okay, good afternoon, everyone. Myself, Dr. Gunjan Verma Shah. I will be presenting various methods of dealing with corneal perforations. A stitch in time saves 9. So, corneal perforations are considered as an ocular emergency because it may lead to microbial entry into the eye. Peripheral anterior synechia formation can be there, which can cause glaucoma, phthisis, and hypotony can cause choroidal detachment or retinal detachment. So there are various factors which govern the management. So it depends upon the cause, whether it is due to an extensive cause or intensive cause, whether there is collagen vascular disease, rheumatoid arthritis, or trauma or infection. The cause will dictate the management. What is the size of perforation, whether it is a large size perforation or it is a small perforation. So, and the location, whether the perforation is in the central part of the cornea or the peripheral part, whether the duration is long, whether the duration of perforation is long or it is a small duration perforation. What is the degree of stromal involvement and melting, and what is the potential visual outcome of the patient? So there are various methods, like first of all is bandage contact lens. We can put a bandage contact lens over small corneal sterile perforation where Seidel test is negative. So, to support the corneal healing. So, other option is a tissue adhesive bandage contact lens, that is cyanoacrylate glue. Then multi-layer amniotic membrane grafting can also be done. Then other method is Tenen patch grafting and corneal patch grafting, which may be full thickness or lamellar thickness, corneal tectonic grafting, and conjunctival flap surgery, that is Gunderson flap surgery. So the cyanoacrylate glue, that is tissue adhesive DCL, it works well for the 3 to 4 millimeter size perforations or impending perforations or the desmatoseals. It has some bacteriostatic properties also, which helps in healing of the patient. Most of the time I do it on a slit lamp examination, slit lamp only under topical anesthesia. We have to debride the epithelium and remove the debris. The area should be dried and the perforation should not be healing, should not be leaking during glue application. Otherwise, it may form a mound over the application site, and the thick layer of glue is not preferable as it may irritate the patient after the application. So pressure reducing agents is also to be given, and the glue can be kept for 4 to 10 weeks. And if it is kept for larger period, it may incite corneal vascularization. So most of the time this cyanoacrylate glue is used. So this is a case of a 24-year-old female who sustained thorn injury and presented to me after the ulcer was perforated, and the AC was flat, and vision was HMPLPR, and glue application was done, and within 1.5 months the AC is very well formed and eye is quiet and patient is enjoying good vision. And the other option is multi-layer amniotic membrane grafting. So stromal matrix is rich in fetal hyaluronic acid. It suppresses TGF-beta signaling and it has anti-inflammatory properties. So multi-layer AMG, it works well in peripheral perforations or in the rheumatoid conditions, in autoimmune disorder and connective tissue disorders. So I will present a case of a 4-year-old male child who presents with complaint of pain, watering, redness since 2 to 3 days. He presented in November 2015, and parent noted a white thing over the cornea, and there was history of wooden stick injury 3 days back while playing. So this was the picture taken on the OT table. There was a foreign body which has perforated the cornea and it was dangling into the anterior chamber. There was surrounding infiltrate and hypopine was there. So in the OT, foreign body removal was done and the infiltrate was excised, but the corneal defect was large to be repaired by suturing only. So tissue was not available at that time. So I made a scaffold with 10-0 nylon, and multi-layer AMG was filled in it, and VCL was put. Intracameral voriconazole was given. Gram QH revealed fungal hyphae, and after 2 months, when the AC was stable and wound was stable, cataract surgery was done, and vision was 624 at first post-op week. So it was in February 2016, and it is in last year, September 2019. There is a small scar over the cornea in the peripheral part, and patient is enjoying 6/12 vision. He is doing very well. Then other method for healing, the perforation is Tenen patch graft. It is described for repair of traumatic scleral perforations and leaking trabeculectomy blades, and it has a defined role in corneal perforation. Tenen is located 2 mm posterior to the limbus and has ability to produce autologous fibroblasts and connective tissue, allowing it to be incorporated into host corneal tissue. So it is an autologous graft. So autologous graft, so no immune response is evoked. Supply is guaranteed and it is cost effective, independent from eye bank supplies. There is no heterologous antigenic sensitization, and the corneal grafting is more likely to succeed if performed at a later stage. So I will present a case of Tenen graft where a 24-year-old male sustained chemical injury in December 2019 in the left eye, and then patient was lost to follow-up, later referred for corneal perforation after 1 month, and he was still instilling prednisolone eye drop. So on the examination, elliptical perforation was noted over the cornea with iris plugging. AC was variable in depth. So this is the no persistent epidefect fluorescent picture. So then during the surgery, I debrided the epithelium, and I made stromal pockets with crescent plate. Tenon graft was harvested from the inferior side, and then tucking was done in the stromal bed, and then sutures were taken over it, and AC was formed with air. So this is the post-operative day 1. And this is post-operative 6 months. In July, the patient had a stable AC, and SR suture removal was done, and there was a vascularized corneal opacity, and this vascularization is decreasing by time. Patient, and the other benefit of doing pin and patch graft is that a patient is most of the time drop free after 5-6 months. And like in corneal grafting, they may require lifelong follow-up. There are chances of rejection. This is the beauty of pin and patch grafting, that patient is drop free after some time. And most of these patients are from lower socioeconomic cases, lower socioeconomic strata. So the financial burden is also reduced to the patient. One other case, this was done during COVID time, when the tissue were not available. This was a 50-year-old male. He had history of trauma with wooden stick, perforated corneal ulcer, vision was HMPL PR. He had lost all hopes of the saving eye. So this was the picture, around 5 to 6 millimeter perforation with iris prolapse. AC was flat. Patient was pseudophakic. So this was done in, I think, July or August, and this is the recent picture. I did a conjunctival hooding over the Tenon grafting, and patient is 618 now. So this was the Tenon patch grafting. Now the other method is tectonic graft, which can be lamellar or full thickness. It is preferred in central large perforations. So this was a female, 50-year-old female. She had perforation for almost 15 to 20 days. And Synechia were also there. So I decided not to try glue DCL, and directly I decided to go for tectonic grafting. And after this grafting, patient is the cataract surgery was also done along with the cardiac surgery, and patient is doing very well. So the take-home message is early intervention in ocular trauma, foreign body injury is mandatory. Wide array of options are available, and timely intervention can save eyes and shape lives. Thank you for your kind attention. Thank you.
Gunjan, very nice presentation. You have covered the whole spectrum of the corneal perforation.
Yes,
how
sir.
to manage them in emergency situations. When the cornea is not available, or in emergency room, you can do all these things. I
Yes,
have
sir.
only one observation to make, that you have mentioned that the tissue glue can be used in case of corneal perforation between 3 to 4 millimeters if the Seidel sign is negative. But 3 to 4 millimeter perforation Seidel sign is going to be positive unless it is a lamellar type of laceration. Second point is that the normal standard stitching is that tissue glue can only be applied if the perforation is up to 2.5 millimeters, not beyond that. You are lucky that you could manage it, but normal stitching is 2.5 millimeters.
Oh.
Good coverage of all spectrum of emergency management of it. Thank you.
Thank you, Dr. Gunjan. It was a nice presentation. So now, for want of time, we move ahead. There are two requests. Dr. Purendra Basin as well as Dr. Lieutenant Colonel Pradeep Kumar has to go to other hall. So I request Dr. Pradeep Kumar, Colonel Pradeep Kumar, to present his talk on traumatic uveitis.
Very good morning to you, sir, and thank you so much for giving me this opportunity. I'm Colonel Pradeep from Army Hospital, Ara, and I'll be speaking about this. So why should we speak about this particular entity? That 4.8% of patients which come to a uveitis clinic have either suffered trauma directly leading to the uveitis or have a trauma-associated aggravation of a pre-existing uveitic condition. These patients are younger in age and work compensation issues are involved. Hence, it is important to understand both the pathogenesis as well as the prognosis of these diseases. The disease burden is quite high because increased clinical visits are required to follow up these patients. And our aim now is to allow our non-ophthalmology friends in emergency departments to identify traumatic uveitis so that treatment can be instituted early and disability can be reduced. So coming to traumatic uveitis, this is the first image which generally pops up in our mind. Multiple sphincteric tears causing a dilated pupil close to about 2 to 3 plus cells and a mild flare. And usually this is where the discussion of traumatic uveitis ends. So the aim of my presentation is to delineate the spectrum of traumatic uveitis, identify a few of the unexplained uveitis, give robust treatment protocols, and to define the role of trauma in other uveitis. Now, this is a very interesting case. This was a 24-year-old male serving soldier who was on the line of control. He was sleeping face down on the pillow on the left-hand side when a shell burst about 5 meters away from his bunker. So this particular patient had a 636 vision in his left eye, had a 1+ AC cells and 2+ vitreous haze, and was being treated initially with topical steroids and systemic NSAIDs. But he had deranged LFT after 2 weeks. His serum ACE levels were increased, and on CCT chest and abdomen, he showed lesions suggestive of sarcoidosis. So this was a case where trauma had incited a pre-existing sarcoidosis for a first-time diagnosis. So coming to the type of traumatic uveitis, it is important to understand that the spectrum starts from the post-surgical cases. Our cataract-induced inflammation is also a traumatic uveitis. The cases of closed globe injury we are very familiar with. Even in open globe injury, when we see inflammation, the mechanism is slightly different from the classical acute anterior uveitis we see. Obviously, sympathetic ophthalmia, lens-induced uveitis remain, and laser-induced uveitis with the increase in retinal treatment. This is one entity we should be careful about. And lastly, even during our ocular examination, if we are doing a very forceful gonioscopy or we are applying the lens over the eye for a longer duration, some inflammation is induced and it should be treated. So the common pathogenesis remains that there are 2 stages of ocular trauma. The morphological response, which is immediate with the swelling of tissues and exudation, followed by the late cellular response when neutrophils start pouring in. So how traumatic uveitis differs from the classical anterior uveitis? Anterior uveitis, it has been proven that fibrin degradation products are raised early, while it does not happen so in case of traumatic uveitis. In case of traumatic uveitis, leukotrienes, they surge ahead and they precede the neutrophil increase. And it is mediated by leukotrienes primarily, but also by prostaglandins, cytokines, and growth factors, which come up in the late stage. So there's a role of prostaglandin inhibition in cases of traumatic uveitis as a prophylaxis also. In cases of lens-induced uveitis, in the acute phase, there are prostaglandin increase, while in the late phase, leukotrienes come in. So this is the reason why when we have a lens-induced uveitis, treating with steroids alone will never help unless the lens tissue is removed from that place, because we don't have a weapon against the leukotriene increase. And lastly, talking about the currently proposed theory of sympathetic ophthalmia, that initially when the injury occurs, you have a non-granulomatous response. This gives you a window period where you can act and prevent it from turning into a granulomatous response at a later stage. And hence, it is important to identify traumatic uveitis early and institute treatment at the stage of non-granulomatous inflammation. Now, coming to other kinds of uveitis where trauma may incite disease activity, the primary one is the HLA-B27 uveitis, ankylosing spondylitis. This is not something we talk about much, sarcoidosis, and acute retinal necrosis. The mechanism is establishment of a positive feedback loop in the predisposed eye. And what we have to tell our patients is that they should prevent ocular trauma. And in case they do suffer from any kind of trauma and they are predisposed, they should see their ophthalmologist immediately. This is one such case where a shuttlecock injury had incited a sarcoidosis reaction. Where we have common pitfalls when dealing with a case of traumatic uveitis, one is that the tobacco dusting of a retinal detachment is sometimes considered a normal inflammatory reaction. Doing an ultrasound and an indirect ophthalmoscopy, if the media allows, helps us in ruling out a retinal detachment. Secondly, the optic neuropathy should not be missed, and we should always look for a sign of reverse RAPD if the affected pupil is dilated. And we should follow up the patient for a slightly longer duration in cases of trauma to rule out one, the sympathetic ophthalmia, and secondly, the retinal detachments. To manage these cases, there is a requirement of breaking the feedback loop early. As I said, it prevents granulomatous conversion. There is a role of NSAIDs, especially in cases of pre-cataract surgery, which all of us use. And now, even in pre-laser cases, we have started giving topical early, and it helps us in preventing most of the side effects of laser. The step-ladder approach remains same in traumatic uveitis also. And in non-resolving cases, whenever there is a history of trauma, think in terms of intraocular foreign body and even exogenous endophthalmitis. Rahi et al. In their paper showed that almost 16% of their cases of endophthalmitis post so-called closed loop injury were culture positive. Follow-up is required to prevent missing out sympathetic ophthalmia and artery. And associated pathologies should be remembered, primarily raised IOP, that is the hypertensive uveitis of trauma, traumatic optic neuropathy, reactivation of herpes simplex both due to trauma as well as the concurrent steroids, and lastly, the epithelial defects. This is one thing where you may keep seeing an increase in inflammation while missing out on a simple epithelial defect. Thank you so much.
Colonel, it was really a great comprehensive review, and really I learned a lot from you today's talk. Thank you once more.
Thank you so much. It's so kind of you.
So for want of time, without any further questions, we are moving to the next presenter. I request Dr. Purendra Bhasin sir, who has to go early, traumatic with Colonel Pradeep, you need to stop sharing screen, and I request Purendra sir to start sharing the screen. आपला internet poor आहे का? Full screen.
Can you see the screen?
Yes, sir. Yes, sir. Make it full.
Yeah, I'm making it.
Please in time, please.
Yes, sir.
Yes, sir.
Thank you. At the outset, I would like to thank DOS for giving me this opportunity and the Ocular Trauma Society of India. And I will be sharing my experience of managing traumatic cataract with zonal dialysis. Can you hear me, please? Yeah.
Mehul sir, you need to unmute.
Subluxation of lens could be mild when it is less than 3 clock hour, moderate when it is 3 to 6 clock hour, and severe when it is more than 6 clock hour. That's what I feel, and I manage the cases as per this the plan. So I will share few cases which will be self-explanatory, and I will be explaining the things and technique in between. This is a 32 years old female who came to us with a complaint of defective vision in the left eye since last 9 years. Right eye vision was 6/6, and left eye with the correction of 3.5 diopter spherical and a 4.5 diopter cylinder, the vision improved to 6/12. She went elsewhere and was advised LASIK laser for left eye. And before she came to us, she didn't give any history of the trauma to the head injury to her. But later on examining and after dilatation examination, we came to know that she had a history of head trauma 11 years back. There was anisocoria, that pupil was slightly dilated in the left eye, and the patient had NS2 cataract with posterior subcapsular cataract, and there was a subluxation of lens. And because of this subluxation, there was an induced cylindrical power, and the vision was not improving to the best possible way. So we planned for laser cataract surgery assisted phaco with the Sioni ring and the capsular retractors. So the point is that any patient who doesn't have a corneal cylinder, but accepting the cylinder in the refraction should be taken with caution. And we should think of a case of the subluxation of the cataract. So this is how we can see that there is a subluxation. Here you can see on the OCT image that there is a subluxation in this region. And this is the OCT image of the patient's eye on laser cataract surgery. So this is the area of subluxation or zonular dialysis which is seen. The good part, we reduced the size of capsular axis and made it slightly eccentric because the lens pushes to the side where the zonules are intact. So we have to slightly change it, and this is possible when the pupil is fully dilated in such cases, and we can do it. We can change the placement of the capsular axis. And by decreasing the size of the capsular axis slightly, we can make an axis. And then after that, nucleus fragmentation was done. And then we took the patient to the OR. And this is how to fixate the Sioni ring. We have made a groove 1.5 millimeter away, and in the sclera, the capsule was pulled out with the free floating capsular axis, and it is taken out, and a gentle hydrodissection is done. As you can say, the patient was young, so the lens was not very dense, the cataract was not very hard, and with the help of, now we could see that this is the area of zonular dialysis, and through this there is a pop-up of the vitreous. So with the vitreous cutter itself, we are removing the cortex, and at the same time we are removing the cutting the vitreous also whenever it comes to the port. So this is how we have, by maintaining the anterior chamber filled with viscoelastic, maintaining the chamber throughout the procedure. Now we have removed the cataract. The bag has to be fixated, otherwise the lens can deform, or the bag can deform, and the lens can go to one side maybe in few years. So for long-term stability and centration of the lens, we should fixate these bags to the sclera, and a Prolene suture, nano-Prolene suture is tied to the Sioni ring haptic, and it is railroaded to and tied to the sclera, and the tip of the sutures are buried in the sclera. A lens is placed inside the bag. The choice could be either single piece or multi-piece. I prefer single piece because it opens up gradually and slowly, and there is hardly any deformation of the bag when we the sudden jerky the IOL opening is there with the 3-piece or multi-piece IOL. The cortex, the conjunctiva is cauterized, and this is the post-operative picture, and the best corrected visual acuity was 6/9 in this particular case, and this has been done almost 3 years back, and the patient is stable. Another case wherein there is a large area of zonular weakness. In this particular case, there is a zonular weakness in both sides, almost 250 to 270 degree. So what we have planned is that after the cataract surgery, phacoemulsification in bag, we will fixate this bag at 2 places. You can see in this area there is a zonular weakness, and this continues from here to this area. So if we straight away go inside, and start doing phacoemulsification, the vitreous will start coming forward and the lens will sag or go behind in the vitreous cavity. It will hang in the vitreous cavity. To prevent it, we have fixated this bag and anchored this bag like a trampoline to the periphery by the capsular retractors, which are fixated at the capsule margin. Okay, sir. So this is how, and then the lens will be placed inside the bag. So, so with this, this is the post-operative picture of this case with the two single Cioni ring with the double fixated at 2 places. Various other cases are there, and because of the paucity of the time, take-home message is that the technique can be used to manage these cases, but one should be prepared to convert to scleral fixated IOL, glued IOL, AC IOL, or iris fixated IOL at any given point of time, because in almost 30% of the cases we are not able to successful to continue with this way. Thank you for the patient hearing.
Thank you, Purendra sir, for display of your skills, surgical skills, and a beautiful videos. Now, for want of time, we are again moving to the next presenter. We have next presenter, Dr. Abhishek, who will be speaking on no perception of light. Dr. Abhishek, you can start sharing your screen, please.
Yes. Is my screen visible?
Yeah.
Yes. Okay, great.
Your screen.
Yeah. So at the outset,
make it a full screen.
Yeah. It is full screen now, sir?
Yes. Yeah. Now yeah. Please.
Okay. So at the outset, I would like to thank the scientific committee of DOS, the chairpersons here, to allow me for this talk. So my topic is regarding the NPL eyes after open globe injury. So is it a lost battle? Traditional teaching that all of us are aware is that with these eyes we either observe or initiate with no light perception after open globe injury to reduce the risk of sympathetic ophthalmia or for cosmetic reasons. But recent evidences show that loss of light perception after open globe injury, however, does not necessarily mean that the patient will have a permanent visual loss. The various articles have been published which have shown that the visual recovery rates from no light perception to light perception or better after globe rupture range from 4% to 33%. So the important thing lies in the assessment of the NLP eyes. Only finding that can ascertain that the no light perception status is permanent after open globe injury is the optic nerve transaction or aversion, which in the case of trauma is difficult to assess. The challenge lies in the confirmation of this entity in the setting of severe globe trauma, as the dual sheath often remains attached to the globe even if retrolaminar neural tissue is disrupted. In cases of partial optic nerve aversion, visual recovery has been documented in few cases. So assessment of light perception by IO is doubtful because this is a psychophysical test and pertaining to the condition of the patient, this test is not very reliable. Same thing happens with DER and ERG. We hope also to assess the cognitive status of the patient, for example, patient's age, unconsciousness, intoxicated or incompetence status of the patient, because this also influences the assessment of the perception of light. Reliability of RAPD is also doubtful because in the cases of dense intraocular hemorrhage and retinal detachments, RAPD can be present. So the wise decision in all these cases is to focus on anatomic findings rather than psychophysical findings when assessing visual prognosis. The steps that can be taken are to identify findings that are amenable to surgical repair, the correction of which may reverse no light perception status, for example, retinal detachment with subretinal hemorrhage or choroidal hemorrhage. Identify findings that are consistent with irreversible visual loss, for example, optic nerve avulsion, optic nerve head transection, or profound loss of intraocular contents. Imaging helps us a lot. B-scan can be done to rule out hemorrhagic choroidal detachments or retinal detachments with subretinal hemorrhages. CT and MRI can help us to identify an optic nerve avulsion, optic nerve transection, or profound loss of intraocular contents. But in the cases of acute severe globe trauma, optic nerve avulsion will be little bit doubtful to assess with the radiological radiodiagnosis. So the surgical approach that we can attain in all these cases is that we have to repair the globe rupture or the laceration first if it is possible, removal of intraocular foreign bodies from the anterior segment, excision or removal of damaged tissues, for example, extruded or contaminated tissue or the cataractous lenses. And if globe cannot be closed, it is reasonable to consider primary enucleation. The suprachoroidal hemorrhage liquefies by typically 2 to 2 weeks of the injury. So at that time, if in the case the setting of suprachoroidal hemorrhage, will be a good time to take up the patient for the retinal detachment surgery. So the things that we need to do depend upon the nature of the injury, and the techniques also depend upon same. Intraocular keratoprosthesis can be used if we are planning it in conjunction with a keratoplasty. Choroidal hemorrhage, if it is present, then a 6 mm infusion cannula can be used, or an AC maintainer can be used for the infusion. Residual lens or foreign body material which is present should be removed. A pars plana vitrectomy for vitreous hemorrhage and the removal of subretinal hemorrhage is done with an open, there is an open break, or if there is any very substantial subfoveal blood. Retinotomy size is to be defined because in these cases, when there is a trauma extending to the zone 3, then the retinal incarceration is there. So relaxing retinotomy needs to be done. To remove the membranes which are present, a bimanual vitrectomy needs to be assessed, and the perfluorocarbon liquids used should be used whenever as it is when necessary. At times, if we encounter cyclitic membranes, and removal of these cyclitic membranes should also be done. The advantages of these eyes is that they can get a better visual acuity, visual recovery. So an article published by Dr. Bhagat et al. Found that of the 17 eyes with final vision of light perception of better, 14 underwent pars plana vitrectomy, and eyes that underwent pars plana vitrectomy were significantly more likely to achieve light perception or better final vision than those which did not. Also, they have found that out of the total NPL eyes, the eyes which were no light perception on day 1 of globe closure, out of them 8% of the eyes they turned to a light perception or better. So in a nutshell, we can say that no light perception after open globe injury does not necessarily mean that the patient will have a permanent loss of vision. Findings associated with permanent profound visual loss after open globe injury include optic nerve avulsion, optic nerve transection, profound loss of intraocular contents, and these can be identified by radio imaging. Eyes with no light perception after open globe injury that undergo successful primary repair with intact optic nerves may be considered for additional surgery, particularly if recovery of light perception on the first day after primary repair is noted. There is a treatable pathology underlying the no light perception status, as for example, extensive choroidal hemorrhage, dense vitreous hemorrhage, and subretinal hemorrhage, or if the fellow eye has no light perception. The chances of recovering ambulatory vision in these cases is usually less than 5%. I thank you all for the patient hearing.
I have a, can I say something? Because I think we have
Thank you,
published,
Abhishek. Please go ahead. Please go ahead,
We have
ma'am.
published an article in the Journal of Retina Vitreous with 430 eyes having no PL, who has regained 29% eye more than PL. So that has been published with my and Rupesh cases. And most important, initial period, if we have a trauma to the optic nerve, there may be a traumatic optic neuritis causing central scotoma, mimicking to the no PL rather not no PL. And in later cases, there are membranes in the pars plana which contract leading to the phthisis bulbi. If we go to far periphery and remove those membranes, so phthisis bulbi can be avoided and eye can regain some vision.
Thank you. Thank you, Mehul sir, for those wonderful words. Because of want of time, we are left with only 12 minutes and 2 more presentations. So we go ahead with the next presenter. It is Dr. V. Jaya Prakash. Can you start sharing your screen, Dr. Jaya? She will be speaking on management of retained intraocular foreign body.
Dr. Jaya there.
He is not there.
Yeah, she was there just now. I don't know. Okay.
Go to next speaker.
I think then the other speakers are all missing now.
Dr. Jayanta is not there.
Jayanta is not there, sir.
Who else? Another one must be.
Jayanta is not there. Then Aditi Agrawal is not there with us.
Yeah.
And V. Jaya Prakash had joined us. I don't know. Now she's just left, I believe. I don't know. So I think we can continue with our discussion. Meanwhile, we have another 7 minutes. So we can have some discussion over it.
Actually, we have as the Mehul brought out the point. These days, the evidence of sympathetic ophthalmia, or the incidence of sympathetic ophthalmia is so less because of many reasons. We don't sacrifice the eye. We rather try to salvage whatever possible, and then in the long run we can decide about it.
Dr. Jay Prakash has joined, so I think we can have his presentation.
Yeah, I think we can.
Dr. Jay Prakash?
Jaya Prakash, hello.
Yes, sir. Good afternoon, everyone. Yeah, I'll
please
just start sharing my slides.
Yeah.
Are my slides visible?
No.
Not yet.
No.
Okay, so just a minute, sir.
Yeah, make it a full screen.
Is it full screen now?
Great. Go ahead.
Thank you, sir.
Yeah, full screen. Go ahead, Dr. Jay Prakash. Yeah.
At the outset, I'd like to thank Delhi Ophthalmology Society for allowing me to make this presentation. Intraocular foreign body is like a ticking time bomb inside the eye and needs early surgical removal. If the foreign body removal is delayed by more than 24 hours, there's a 4-fold increase in endophthalmitis and also the risk of toxic damage. In rare instances, we may defer the removal of foreign body if it is inert and if the removal process would cause more damage than benefit by removing the foreign body. The damage due to the foreign body depends upon the size, shape of the foreign body, momentum at the time of impact, the composition of the foreign body, whether it's contaminated or not, the location, and associated structural damage. Foreign bodies are present in about 10 to 40% of all open globe injuries and are commonly seen in young males. It's usually common in an industrial setting, and the most common mechanism is a chisel hammer injury. Foreign bodies can be metallic or non-metallic, and metallic can be magnetic or non-magnetic. Non-metallic foreign bodies can be organic or inorganic. The site of the foreign body can be in the anterior segment, posterior segment, adnexa, or it can be partly in each of these segments. Intravitreal foreign bodies are the most common. Now, the foreign body gains access to the vitreous cavity through the cornea, limbus, or sclera. Through the cornea is the most common route. It goes to the pupil or iris through the lens or the zonules and comes to the vitreous cavity. Through the sclera, it's to the choroid, retina, and the vitreous cavity. The scleral entry leads to more damage than a corneal or limbal entry. When you see a patient with an intraocular foreign body, you have to have a clinical flight plan. You have to first identify light-threatening trauma, check the vital signs, look for skull and cerebral damage, take a good history of the circumstances of the trauma, the size, shape, speed, density, composition of the foreign body, and the time elapsed since the trauma. A thorough and gentle ocular examination is necessary, after which an eye shield can be put and the patient can be put on nil per oral in anticipation of surgery. Tetanus toxoid and systemic antibiotics can be started. Appropriate imaging should be done. It's very important to prognosticate and counsel the patient very well before any surgery. If it's a long-standing foreign body and toxicity is suspected, in ERG can be done. The goal of the intervention is to close the entry site, prevent endophthalmitis, and to do safe removal of the intraocular foreign body. Long-term care involves modulation of inflammation, observation for infection and sympathetic ophthalmia, surgery for RD and PVR, and amblyopia prevention in the pediatric age group. Ocular examination consists of visual acuity examination and pupillary examination, assessing the foreign body penetration site and the media clarity. You have to look at globe rupture signs like a shallow AC, subconjunctival hemorrhage, chemosis, low IOP, sedals, and UL prolapse. For vitreous hemorrhage, retinal tear or detachment, endophthalmitis, and panophthalmitis. Suspicion of foreign body should be there in patients with unilateral uveitis, progressive cataract, heterochromia, recurrent iris, hyphema. When there are iris holes, focal lens opacities or tract, or vitreous tract, or an intraocular mass or hemorrhage, also a foreign body should be suspected. Sometimes the foreign body can be hidden in the angle, so gonioscopy is needed. It can be also hidden in the pars plana, so good indirect ophthalmoscopic examination with depression is required. However, this is not possible in an open globe injury. So that brings us to imaging. Imaging helps us to confirm the diagnosis for medical legal purposes, to localize the foreign bodies, especially in a setting of a blast or a firecracker injury. A simple X-ray or a limbal ring can be done. Ultrasound, anti-segment OCT, UBM, and CT are also very helpful. The ultrasound shows the foreign body as a high reflective echo persisting in low gain with back shadowing. A spherical foreign body can have a comet-tail artifact. Ultrasound is very useful to detect coexisting ocular pathology and is also inexpensive. However, CT and MRI are user-independent and non-contact procedures. CT also gives about details about the orbital wall fracture. MRI gives good soft tissue imaging and detects glass, plastic, and wooden foreign bodies better, but should not be done when you're suspecting a metallic foreign body. Foreign body removal can be done along with the primary repair as a subsequent procedure. In the primary repair, it decreases the rate of end-off, can avoid a second procedure and prevent RD and PVR. A subsequent procedure, the inflammation is better controlled, and you can the patient is also stabilized to years to time. This is a patient with a foreign body in the anterior chamber. So a side port was made and the foreign body was viscoaspirated. The foreign body is impacted on the retina. This is a magnetic metallic foreign body. So PVD vitrectomy was done, PVD was induced, and the site of the foreign body impaction is cleared of all vitreous. Laser barrage is done before trying to manipulate the foreign body out of the site. A magnet or a forceps can be used to remove the foreign body. It is removed by a handshake technique. The second video also shows the removal of a foreign body through a scleral route. The long axis of the foreign body has to be oriented along the long axis of the instrument which is used so that the scleral wound made is smaller. A larger foreign body we'll have to remove through a limbal route. So this is a glass foreign body removed through the limbal route. This is a large bullet, so we had to take it through an open sky route, after which a penetrating keratoplasty was done. Foreign bodies with ragged edges can cause more trauma when they are removed. So you have to be very gentle and careful while removing them out of the eye. Organic foreign bodies like caterpillar hairs can be multiple and can be located in the pars plana area. So depression and careful removal of the multiple caterpillar hairs are very important. This is a patient with a foreign body impacted on the retina. So a lensectomy, vitrectomy was done. The site of the foreign body was cleared of the vitreous hemorrhage. Endolaser the chemo was cleared. Endolaser was done at that site. And despite multiple attempts, we could not remove the foreign body from the internal route. So that's when we realized that most of the foreign body was outside the eye and we had to do an external route to remove the foreign body. So the poor prognostic factors in the presence of foreign body are endophthalmitis, retinal detachment and PVR, chalcosis and siderosis, sympathetic ophthalmia, optic atrophy and ERM. Rarely the eye may need evisceration and the eye may go into phthisis. So to conclude, foreign body should be suspected based on the circumstances of injury. Appropriate imaging is necessary. Early aggressive management is necessary for foreign body removal. Counseling the patient attended is very important. Guardian visual prognosis should be explained for endophthalmitis and RD. And protective eyewear has to be advised to prevent ocular trauma. Thank you.
Thank you, Dr. Jayapur. Wonderful bouquet of cases of intraocular retin, intraocular foreign bodies, as expected from a Shankar Nethralaya consultant. Congratulations once more. I think we are just, we have 3 minutes left for us for the discussion. So over to you, Mukherjee sir and Grover sir.
I think we had a very nice presentation on no PLIs and the huge series that Dr. Mehul talked about. That is a very important lesson for all traumatologists to learn, that wherever feasible, as Dr. Mukherjee was saying, save those eyes. And as they said, do try with the vitreous surgery wherever there is a possibility of trying and restoring some kind of a vision and at least maintaining the structure. I think that is a very valuable lesson which we should carry home as a message today.
In general, I would say that all the papers, all the talks were very nice, very educative. But as Ashok pointed out, that was the talk where we have the carry home message that we must try to salvage the eyes as far as possible rather than sacrificing the eyes. And I must, if we are concluding, then I must thank Mehul, Dr. Prashant, Dr. Kuwar, and Dr. Sanjeev. So Sanjeev joined a little late, but all these people in the chair, of course, very nice interactive session. And I must thank all of you. Any other person, any other thing to comment? And one point I would like to just remind you that on the 24th we have, or rather 27th we have the executive meeting of OTSI.
Okay, sir. I think we are quite in time. We have finished exactly a minute ahead of our allotted time. So thank you, Dolls, for this opportunity to Ocular Trauma Society of India. We, on behalf of OTSI, are thankful to you, and hereby we sign off. Thank you once more. Thank you.
Good time, Master Prashant.
Thank you once more.
And thank you, President.
Bye, sir.
Thank you.
Thank you, Mehul.
Bye, Grover sir. Bye, Mukherjee sir.
Bye, bye, Mehul.
Bye, sir. Bye.
See you all again.
Hello, Gunjan ma'am. Hello. 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 Hello, Dr. Gunjan. Hello, Madhvi ma'am. Hello.
Yes.
Yes, ma'am. You can screen
Yes,
share.
Can you hear me, Dhruvan?
Yes, ma'am.
Yeah. So now, can I just share my screen and see one?
Yes, ma'am. You can do it.
Yes, just a moment.
उसमें 3 से 4 बजे में आपका 4:30 बजे तक आपका हॉल आई में है तो करनी है रोल आपको ज्वाइन करना है
Yes, ma'am. It is visible.
ओके सर हाँ 3 बजे सर 3 बजे सेशन है आपका ओके सर तो आप ज्वाइन कीजिए हाँ और लिंक लिंक है ना सर आपके पास फैकल्टी वाला
Is it visible? Can you see it full screen?
मैं भिजवाता हूँ
Yes, ma'am.
2 सेकंड दीजिए
You can see.
लिंक फॉरवर्ड कर रहा हूँ हेलो हाँ सर बोलिए
Yes, ma'am.
Can I just check
आवाज
the
कट रही है आपकी. Hello.
one minute? Can you see the video?
No, ma'am. Only PPT.
Can you see?
Only PPT.
Only PPT is being seen, is it?
हाँ तो सर आपका हॉल कौन सा है सर हॉल एच तो सर आप वो फैकल्टी लिंक पे क्लिक कीजिए
यूज कर सकते हैं ध्रुविन
Yes, ma'am.
Can I use a hyperlink or only
Hyperlink.
VLC player?
VLC player, ma'am.
Only VLC player. Okay. Fine. I will try. There's some time, no? I'll finish by then. Anyway, PPT is being seen, no?
Yes, ma'am. Consider a scenario.
Consider a scenario. Okay. I mean, now the whole screen also is being seen. SICS, my savior at times. Can be seen, no?
Yes, whole thing.
Okay. Fine. I will see whether I can go into VLC player. I'll just do it. Okay,
ma'am. Okay.
Yeah. I'll stop sharing. 1 minute. Okay. So I'll leave now. I'll come again.
Okay, ma'am. Okay.
Thanks, Dhruvi.
Welcome, ma'am. अरे व्हाट्सएप में अच्छा नहीं કહેવાને G for Buga. डॉक्टर रुचि मैम, मैं डॉस इवेंट से बात कर रहा हूँ। आपका सेशन था 3 बजे। ओके मैम, सॉरी टू बॉदर यू। मॉडरेटर ना पड़ा क्या मुने यार, बड़े बड़े इवेंट में। डॉक्टर अरुण सेंगल सर, मैं डॉस इवेंट से बात कर रहा हूँ। डॉस इवेंट, आपका पैनलिस्ट में नाम था ना सर? डॉस इवेंट 3 बजे था है। Try to join 10 to 15 minutes before 3. Okay, thank you, sir. डॉक्टर मीता जोशी मैम, मैं डॉस इवेंट से बात कर रहा हूँ। 3 बजे सेशन था ना, उसके लिए रिमाइंडर। ट्राई टू ज्वाइन बिफोर 10 to 15 minutes. थैंक यू। सर मैं डॉस इवेंट से बात कर रहा हूँ 3 बजे सेशन था उसके लिए रिमाइंडर प्लीज ट्राई टू ज्वाइन बिफोर 10 to 15 minutes I will send it on WhatsApp. Sorry sir. Sir, it is okay. Okay, sir.
Hello. 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 Okay. आपका शेयर स्टार्ट होने वाला है बात कर रहा हूँ हेलो डॉक्टर देश पांडे सर हाँ सर मैं यूएस 2020 से बात कर रहा हूँ हाँ सर अभी हॉल जे में एट 3 PM योर सेशन विल स्टार्ट सर मैं अभी आपको डायरेक्ट ज्वाइन करवाता हूँ अभी मैं आपको सर मैं अभी आपको डायरेक्ट ज्वाइन करवाता हूँ हाँ तो सर अभी आप जूम अभी ओपन कीजिए जूम एप्लीकेशन को हाँ जूम ओपन कर दो बहुत सारा ओपन वहाँ पे सर ज्वाइन अ मीटिंग कीजिए तो सर ऑप्शन क्या आ रहा है स्टार्ट कीजिए सर
डॉक्टर देव प्रसाद
सर मीटिंग आईडी पूछ रहा है सर वो
सर मैं डॉस इवेंट से बात कर रहा हूँ आपका सेशन था 3 बजे
ओके सर तो मैं आपको मीटिंग का सर मैं आपको लिंक भेजता हूँ
हाँ तो सर प्लीज ज्वाइन कर
ईमेल
दीजिएगा
करता हूँ सर मैं आपको
ज्वाइन कर दीजिएगा ना सर बिफोर टू 10 or 15 minutes ओके थैंक यू सर
Hello, am I audible?
Yes, ma'am.
Hello, I'm one of the participants for free paper presentation from 3 o'clock onwards. I think I've joined a little earlier.
Sorry, ma'am.
मेरा प्रेजेंटेशन है 3 बजे से है शायद, तो मैंने मतलब 3 बजे से है तो मैंने थोड़ा जल्दी ज्वाइन कर लिया. मैं लीव कर दूं, दोबारा ज्वाइन कर लूं या अभी लॉग्ड इन नहीं रहूं?
सॉरी मैम, आपका नेम नहीं है इसमें.
डॉक्टर नितिका बेरी. नितिका बेरी.
दूसरे हॉल में होगा, आई में था.
अच्छा, ओके फाइन, ये आई है. ओके सॉरी, आई थिंक आई कम टू द रॉन्ग वन. थैंक यू.
ओके मैम. हेलो.
Hello. Hello.
Wait a moment, sir, please.
This is for SICS stock, na?
Yes. Thanks.
Regarding the SICS stock basics,
Yes, yes.
can I just check whether I can share my presentation?
Yes, sir.
Should I share it now?
Yes, sir.
I don't have.
Yes, sir. It works smoothly.
No problem.
No.
Am I audible nicely?
Yes, perfect.
Just a minute. I will just go through it.
Yes, sir.
You are going to start at what time?
At 3.
Okay. Okay. Thank you.
Yes, sir.
Dr. Malik sir, you have some problem. Hello, good afternoon, everybody. Are we able to hear each other? I can't hear anybody. Can anybody hear me?
Yeah, yeah.
Yes,
We can hear
sir.
you.
Is Dr. KPS Malik connected? Is the chairperson?
Yes, sir. We can hear you, sir.
Okay. Okay.
Yeah, we can hear you clearly, sir.
No, you can hear me, but what about the chairperson? Chair, somebody should start the session.
I think KPS Malik's name is there. डॉक्टर साहब का नाम तो है वहाँ पे.
तो अगर वो सर नहीं है तो डॉक्टर योरसेल्फ और डॉक्टर गोगटे कैन स्टार्ट.
डॉक्टर गोगटे परीक्षित is the first presenter ready for presenting?
Sir, I am the first presenter.
Fine. Dr. Parikshit, would you like to? Dr. Parikshit?
Yes, Mr. Ravindra, sir.
Can you start the program? I think Dr. Malik is not checked in yet.
Yes, sir. I think so this is Malik sir's screen that I am seeing, sir.
Malik sir, he's
Dr. KPS Malik sir's screen.
Dr. Malik sir? You're already on Zoom, sir. You're trying to enter Zoom once more with another gadget.
But Dr. Malik's name is there.
His name is there.
His name is there in the connected people.
Sir, Dr. Manavdeep Singh is the first presenter. So I think we should ask Dr. Manavdeep Singh to start presenting. Sir.
I think then Dr. Malik has to unshare his.
Dr. Manavdeep, sir.
Sir, somebody has to unshare the screen. Unless this screen, I cannot share the screen till this is unshared. This must.
There is somebody from DOS backend co-hosting this program. Can you help? Timer is there co-hosting this program. Can you help us? Sir, Dr. Malik, sir, you are already on the board. I think you are trying to join again. Dr. Malik, sir, Professor Malik. Can you unshare your screen? Mr. Dubin? Okay, now, sir, please go ahead. Please go ahead.
Okay, right, sir, right. Thank you.
So I think you please start, Manavdeep Singh, sir.
Yes.
Right, sir, right.
You don't need an introduction in Delhi, sir.
No, sorry. This is the wrong presentation opened. And the last article. So now can you see?
Yes, sir.
Can you see my slide, please?
Yes, sir. Raw start of ECC. Kindly go ahead, sir.
Yeah.
Yes, sir.
Right. So most of us are no more doing ECC, and but I have certain things to show that in these kind of situations, Phaco may be difficult and ECC may be very, very easy. And all of you know this, and there are no problems for ECC in this kind of small pupils either. And in vascularized corneas, opaque corneas, poor visibility, phaco is very difficult. So we should know this. I'm not saying this is a procedure to be done, but everybody should know this procedure. It's conceptually different from the closed chamber surgery, and we have to have a paradigm shift. Earlier, we shifted from ECC to the closed chamber surgery, and now people have to shift the other way around. So that mental paradigm shift is required. And the pressure and AC depth changes in the ECC can be very painful. So we need a peribulbar block, and topical is not enough. The closed chamber, avoid pressure on the globe. So we should avoid speculum. It is less forgiving in some steps and more forgiving in the other. So this peribulbar block is an essential, and a good massage and low IOP is required, unlike SICS where little higher pressure is required. So no speculum. And I'm showing some videos, and this is a corneal scleral groove and entry. What I do is I just cut with a blade with the 11 number or with the razor blade, and I enter with the same, and do not make a conjunctival flap. So that makes it faster and easier. And this is limbar cautery, which is not really required in most of the cases, but in vascularized corneas, yes, this may be required. The corneal scleral section making is done by universal corneal scleral scissors mostly. Right and left can be used, but mostly they are not used. And so this is to be done in the groove on both the sides, right and left side. So this is how it is, and the conjunctiva automatically retracts. And then the capsulotomy. Capsulotomy, the principle is same as everywhere here. The reverse D capsulotomy is the most preferred. We give radial cuts and then join them. In capsulorhexis, if we can do that, but subincisional removal of the cataract may be very difficult. Can opener is less safe, so this is the most preferred technique. And this is now showing in the mature cataract, same thing. Visibility is not really very important. You don't need to see the cuts. That's not very important in decapsulotomy. So this is showing the layers and the hydro procedures. All of us know this is an old. So this is an animation showing hydro procedures, hydro dissection, and then hydro delineation. These are as important in ECC as in phacoemulsification, because this will reduce the size of the section that is required if you do appropriately. And this is showing the same thing in a clinical case. And this is done after opening the full section. It is not done in a closed chamber. So that is an important thing to remember. The nucleus delivery, enlarge the section, rotate the nucleus. Relaxing incisions are required in case a capsulorhexis has been done. So inject the visco to safeguard the corneal endothelium, but it is required only at the section area and nowhere else. Some people do give a pre-placed corneal suture as well. So this is another animation showing the same thing. I use for this simple corneal scissors and limbs forceps because they are already in my hand, and I don't need to change the instruments. The sliding force is done after starting from the limbus, and the posterior lip is pressed with the left hand. So this is the nucleus delivery being shown in an actual case. There has to be alternate pressure given on the two instruments. If there is any problem, if the nucleus gets stuck, increase the size of the section. So this is what it is. Press the posterior lip and then slide from the lower portion. And this is visco expression of the epinucleus. You can loosen it if it has not been loosened fully by hydro procedures, then you can loosen it further with Simcoe cannula. And once it is loosened, then you can just inject visco beyond the epinucleus, and then with the two pressures. I learned all these things mostly. So many things I learned from Parikshit Gogte, who is although much younger than me, but I learned many things from him. The same thing can be done by applying pre-placed sutures, especially in case there is an iris prolapse, and you can use the automated IA as well, in case you are more comfortable with this. The principle remains the same section, that you hold the cortical matter in the periphery, bring it to the center, and apply the suction in the center for the safety of the whole procedure. This is in a clinical case with the Simcoe cannula. This is Simcoe cannula. You hold it in the periphery, bring it in the center, and then pull it further. Increase the aspiration pressure when you are in the center. So now the IOL implantation. It is, you can see here, can you see this anterior capsule? So you can place it in the bag. It is a 6.25 mm lens. Still, you can easily put it in the bag, and this anterior capsule, which is clearly visible, so it is in the bag. With reverse decapsulotomy, this is possible. Or you can do CCC with radial relaxing incisions. So this is about anterior capsulectomy that is done at the end. You put some visco here and then cut it with angled Vanna scissors, and then rotate it with either capsulorhexis forceps or with McPherson forceps. This visco was put so that the flap is lifted. So this is the implantation. You can see this stretch line in the posterior capsule that proves that the IOL is in the bag. Same stretch line is visible here as well. And this is application of sutures. You can apply either continuous or interrupted. I apply continuous sutures starting with the sclera. And the knot is triple knot, as all of you know, 3, 2, and 1 for every 10-0 suturing. So visco expression is done at high aspiration and post-op, the less chances of raised IOP in this ECC, because there are small areas of openings. Compared to that, problem is not there. The raised IOP is not a problem in, even if slight amount of visco is left in ECC, it is much bigger a problem in a closed chamber surgery. So this is the final appearance at the end surgery. And this is post-op day 1 in a mature cataract. There is absolutely no SK, and the cornea is absolutely crystal clear. Just to summarize, during this procedure, keep IOP low by preoperative massage. Use lid sutures and not the speculum. Avoid using cautery. Hydro procedures are safer in open section. Simcoe is safer and less messy than automated IA. In these cases, possibility to implant IOL is there in the bag. So constrict the pupil at the end and bury the knots to avoid post-op irritation. And ECC is not a taboo. It may be a savior occasionally in certain selected cases. So thank you very much for the patient listening. Sir, I've stopped sharing. Please go ahead.
Fine. Thank you very much for taking us back through the journey of cataract surgery. Am I audible?
Yes, sir, you are audible, sir, but I'll have to take a leave because I have another session to go in.
Sure, sir. Thank you. Thank you so much. We'll go on. I would like to remind that all the presentations are for 7 minutes, and kindly try to complete by 6 minutes so that we can have 1 minute of discussion at the end of it. Otherwise, we'll be losing on discussions. Welcome to Dr. Malik, sir. Can we go on to the next presentation? That will be Tunnel Pathways by Dr. Pankaj Shah. After that, Dev Prasad ji, be ready to start your lecture. Dr. Pankaj Shah.
Yes, sir. Good afternoon.
Good afternoon.
Am I audible?
Yes, you're audible. Very much. Kindly share your screen.
Yeah. Is it visible, sir?
Yes.
Thank you. Good afternoon, all panelists. And at the outset, I thank Delhi Ophthalmic Society and all of you for giving me a chance to present. I will be speaking on tunnel, which is learning pathways. Introduction. Wound is not just a portal of entry into the anterior segment. And now cataract surgery has become a form of refractive surgery offering improvements in best corrected and uncorrected visual acuity. Let's go about the history, where many of them have worked on the incisions like Kratz. He moved the incision posteriorly from the limbus. Girard and Hoffman called it a scleral tunnel. Ernest and McFarland introduced a triplanar incision. Paul Cox introduced incisional funnel, and Howard Fine gave clear corneal incision. So what are the parts of the tunnel? The tunnel has an external incision and tissue dissection and internal incision. The parameters of the tunnel are it should have a depth, width, and length. Advantages of scleral tunnel. The surgical advantages are it has less incidence of iris prolapse, watertight, so decreased incidence of expulsive hemorrhage. And the advantages to the patient, stronger wound permitting greater range in postoperative activities, no suture-induced foreign body sensation and astigmatism. Also called external incision scleral groove. It is 0.3 to 0.5 millimeter into the sclera and should be of uniform depth. If the flap is thin, there can be, because tears and shredding, buttonholing, which can cause infection, and also stretches which can give rise to against-the-roll astigmatism. Thick flap usually has no problem, but can have scleral insertion and bleeding, difficult to suture the wound, and chances of choroidal nicking and bleeding and premature entry. It is a distance between external and internal incision. The advantages, less astigmatism, more stability, more strength. Disadvantages are overlocking of the probe, difficult to construct, corneal folds decrease visibility, and tunnel burns gives sleeve compression. The length of the incision is always depend on the size of the IOL to be inserted, ideally 3 millimeter or 5 millimeter or 6.5 millimeter. Induced astigmatism is directly proportional to the cube of the length of the groove. 1 or 2 side ports depending on the surgeon, 2 or 3 clock hours from the main incision. It can be done with 15-degree or 30-degree paracentesis blade. Construction of the side port is slightly clear corneal. Plane of the blade should be parallel to the iris plane, and take care not to damage the iris and anterior capsule. Incision. The incisions can be classified as on the site of the incision or the part. So depending on the site, it is a superior incision, a superior temporal incision, or a temporal incision. Also, it could be a scleral, limbal, or clear corneal. Superior incision is ideally between 11 and 1 o'clock. The advantages are maximum protection against infection and easy for beginners. The disadvantage is difficult to construct and work in deep-seated eyes, poor visibility, corneal folds, less red glow, difficult in cases of filtering surgery, and maximum against the roll astigmatism. Between 8 and 10 o'clock, it's easy to make, manipulate in deep-seated eyes, good tissue visibility, maximum red glow, and all types of cases, less foreign body sensation. But disadvantages are there are more chances of infection, and sitting position may be difficult for few. Clear corneal incisions, they are simple and fast, best with diamond blades. It is a single plane incision, single blade, no groove, no cautery, no scleral tunnel, and easy for topical anesthesia. But disadvantages are more chances of infection, more endothelial damage, increased astigmatism if it's more than 5 millimeter. So what is an ideal tunnel? It has been described as a square tunnel which is the most stable, strong tunnel and is maximum watertight. A tunnel of equal length and width. It induces least or no astigmatism. These are the various techniques, tunnel making and extension of the wound, construction of the tunnel. Considering above the astigmatism, a tunnel incision causes flattening of the meridian in which the incision is taken. Hence, external incision should be taken in the steepest meridian. What are the various incisional funnel? It's known as, which is bounded by 2 curved lines, and incisions made within the funnel are astigmatism equivalent. A curvilinear incision gives maximum against the rule astigmatism. Straight line gives less. Frown and chevron incision gives the least astigmatism. Also, it depends on the site of the incision. A superior incision, more ATR. Superotemporal, moderate. And temporal incision gives the least astigmatism. These are the various types of incision: classical concave or frown or chevron incision or straight incision. Shape of the incisions again. What are the effects of sutures on the incision? Horizontal or radial sutures, and effect of instruments. Diamond blades give clean, precise and regular incision. Steel blades can give ragged and irregular incisions. Complications: there can be premature entry, buttonholing of the flap, scleral disinsertion, tunnel burns. Could be because of long tunnel, high ultrasound energy, low flow rate, sleeve aging and tight tunnel. Management of buttonholing is it is a cut through the scleral roof, abandon the original dissection, start at the opposite end, deeper dissection and sweep laterally. Avoid bunching of advancing scleral tissue at the crescent blade advances towards the cervical nimbus. How can you manage the premature entry? Start fresh with less depth of dissection into the sclera, avoid aggressive angling, increase the dissection into the clear cornea and suture the tunnel. When there is a scleral disinsertion, it can occur when the scleral groove is very thick or deep. Radial suture should be used to oppose the edges of the scleral groove. Suturing of the tunnel, it is indicated in premature entry and weak tunnels. Radial sutures having vertical component cause post-operative with the rule astigmatism. Horizontal suture is most physiological to the scleral tunnel and causes less with the rule astigmatism. These are the suturing techniques. Infinity suture, which is completed. The other complication which can occur during tunnel is Descemet stripping. It could be because of the cannula tip in corneal canal causing intralamellar hydrodissection due to saline or viscoelastic, or during tunnel construction. It should be managed carefully. Careful instrumentation should be there. Injection of air bubble, and if inferior half of the cornea reposite with viscoelastics. And if there is large Descemet membrane, full thickness corneal suturing should be there. I hear, I forget, I see, I remember, I do, I understand. Tunnel making is an art, best master for best results. Thank you, all of you.
Yeah. Thank you, sir. It's a beautiful lecture. You covered the entire thing in 7 minutes time, sharp. And Dr. Malik, would you like to comment on his presentation? Dr. Malik, sir?
Yes, can you hear me?
Yes, sir. Yes, sir.
We can hear.
It's okay making the tunnel, and like I think everybody learns that you have to have how much outside the bus and how much inside. You must be having a control of your this one, that don't go far behind, that you can't control the entry of your instruments. Only thing in the tunnel, like valvular thing, should be in the cornea. That cornea you must have at least 2 millimeter valve. So that is one I would like. Otherwise, outside you can have 5.5 or even 4.5, or Dr. Ravindra has a standard 6 millimeter. So he is happy whole life with it. I make between 5 and 5.5. But I insist for beginner that you have it near the limbus and don't go far behind.
Right, sir.
Yes. So basically inside you have to have 7.5 millimeter entry, and that valve effect is in the cornea. The cornea must be at least 2 millimeter dissected. That's well done. Anyway, the next speaker can be called.
Yeah, I have a few observations before Dr. Dev Prasad comes and presents his paper. You can start presenting. And the instruments in SICS have to be as good as any other surgery. And Dr. Saab even told about diamond knives. Diamond knives are superfluous in today because steel blades are extremely good. They're almost as good as them. But do discard bad knives immediately. Doesn't mean that you'll have to use cheap instruments when you're doing SICS. And about the tunnel, its length and width cannot be same, as you know. It's not practical, so it has to be. You'll have to get a continuous feedback of SIA and modify your tunnel. And in my hands, there is no difference between tight incision as well as strong incision. There's no hand, so I straightaway go for a tight incision in all the patients. It is not only the size of incision that's important, but also the stretch that you do during the surgery. Imagine you got a smaller tunnel and stretch the tunnel with a large amount of very hard nucleus, you're going to induce a lot of astigmatism in that patient. Again, as is rightly said, a lot of carpentry will modify this little healing. And when there is a buttonhole or a premature entry, I have it now. I don't go to another area. In the same area, if you have a nice blade, I mean, imagine you have got a premature entry. You withdraw it in the same plane. You don't have to go anywhere else. Imagine you have made a 2 millimeter entry into the antechamber. You can come back and go a little superficial and make another one. So you can use the same site in both the situations, wherever you have a premature entry as well as button holding. Try to use the same instead of going elsewhere, because you're sat there, you're just at your microscope, the patient is comfortable, you've chosen the best site, steep meridian, whatever it is. At the end of it, if you think the wound is not opposing properly, you can take a radial stitch. Between the radial and infinity stitch, I always prefer one single radial stitch in the center of the tunnel. See that if that's a deep lamina, that's a superficial lamina, form the chamber with fluid and see that the normal pressure is reached, then you take one bite exactly. Don't hold any tissue. Pass the needle together across the outer edge of the tunnel, and then see that when you tighten it, do not tighten it. Your aim is only to oppose the tissues, not to tighten it. The tunnel will take care of it. That will minimize the astigmatism. You can take the help of intraoperative keratoscope or a ring, any kind of a ring or a back of a safety pin. See that when you're tightening the second knot, see that the circle is circular. So you'll not get very surprised astigmatism in these patients. Let us hear Dr. Dev Prasad, who is going to talk on incisions and astigmatism.
Yeah, am I audible now?
You're
audible?
Yeah. Please go ahead. You have 7 minutes, Dr.
Yeah. Good afternoon, everyone. At the outset, I would like to thank DOS for giving me an opportunity. I would like to, it's an honor and a privilege for me to talk in front of so many stalwarts in SICS. Today's talk, my topic would be incisions and astigmatism control in MS-ICS. So there will be a lot of overlap in the talk because other people also are having the same kind of topics. Wound construction, the main highlights of a wound construction, it should be a small, it should be a self-sealing, and it should be ideally be a sclerocorneal tunnel so that the tunnel effect is intact. Though the tunnel should have appropriate length depending on the density of the nucleus. You can titrate your length based on the density of cataract. If it's a hard cataract, you can make a 6 to 6.5 millimeter incision. If it's a soft cataract, you can get away with only a 4.5 or a 5 millimeter incision. And the shape or style could be anything. It could be straight, your front, your chevron incision, or a straight incision to the back cuts. A location, depending on the steeper meridian, you can plan it either superior temporally, or totally temporal. And depth, width, and entry place. The entry place, the keratome should enter at the corneal level inside the anterior chamber. And the shape of the tunnel should always be trapezoidal. If the shape doesn't come as trapezoidal, there will be a lot of against the rule astigmatism. Ideal incision should be 3 millimeter posterior to the limbus. The length could be anywhere from 5.5 to 7 millimeter length. The depth should be 0.3, and the most important thing, the width. It should be around 4 millimeter. The small nucleus can be, the small incision can take in a soft nucleus very easily, but for a dense cataract, you need a large incision. So the cornea as such is not spherical in shape. It is roughly, you can tell it is a shape of a rugby ball. So we don't have same keratometric reading in all the surface of the cornea. We have a steeper meridian and a flat meridian. The steeper meridian is usually the vertical plane, and the horizontal meridian is the horizontal plane. So with the rule, astigmatism is defined as when the greatest refractive error is within 30 degrees of the vertical meridian. So this is corrected by a concave cylinder at horizontal axis or convex at 90-degree axis. Against the rule, astigmatism is when the refractive power is within 30 degrees of the horizontal meridian. It is corrected with a concave cylinder at vertical axis or a convex cylinder at a 180-degree axis. So with the rule axis is most commonly seen in younger patients and myopic eyes, where the steeper axis is 90 degrees, whereas the against the rule astigmatism, the steeper axis is 180 degrees, and it's more commonly seen in cataract patients, older patients. Sorry. So oblique astigmatism is also seen in some patients with the greatest refractive power is within 30 degrees of the oblique meridian, that is between 30 and 60 or 120 and 150. So pre-existing astigmatism is already present in the patient. The final astigmatic error depends to a large extent on the preoperative astigmatism. So always you should plan the incision on the steeper meridian. You see whether the horizontal or the vertical, whichever was most steeper, you place the incision on that, and the wound characteristic, and modify the wound characteristic based on the density of the cataract. So ideally the cornea can be divided into meridians, the horizontal meridian and the vertical meridian, and depending on the steeper meridian, you can plan your incision. This is represented by a protractor placed on the cornea. So how do you measure this thing? Measurement can be through retinoscopy, through keratometry, or corneal topography. Ideally, if you do a corneal topography, we can know which is against the rule or with the rule astigmatism, and you can plan your incision, and also you can titrate your incision by putting the cardinal suture. So the central keratometry reading, it usually measures the central curvature of the cornea, and it provides dioptric power in steepest and flatter meridian and defines its location. So we should be able to detect the astigmatism whether it is irregular or regular, and then if it is keratoconus, then you need to plan it appropriately. So the difference between the horizontal meridian and the vertical meridian is what constitutes the corneal astigmatism. So plus cylinder, the axis is the axis of the higher dioptric power, whereas minus cylinder, the axis is the lower dioptric power. So incisions could be anything. It could be a straight incision, or you could put a Fron incision, chevron, or an inverted batwing incision, or where usually the Blumenthal technique, where you take a side cuts. So whatever incision is made, the incision should be closer to the limbus. If the astigmatism is the pre-existing astigmatism is little on the higher side, it's better to go closer to the limbus. Whereas if the astigmatism is lesser, it's always better to go away from the limbus. This will ensure that the post-surgical astigmatism is neutral or in a minimal quantity. So ideally the incision should be 4 to 5 millimeter external opening, but the internal opening should be little wider so that it can engage even a denser cataract. And the scleral pocket should be around 4 millimeter, which includes the scleral extent of 2.5 and 1.5 to 2 millimeter of the corneal side. So whatever incisions you plan, you should always follow the incisional funnel. So when you respect the incisional funnel, the astigmatism can be titrated appropriately. So what are the pearls? Pearls is whenever you're doing a sclerocorneal tunnel, the heel of the crescent should always be flat on the globe, so that it's just visible through the sclera. If it is not visible to the sclera, that means it is going very deep. Or if it is very superficially visible, that means you are creating a button hole. And keratome should, the movement of the keratome is very, very important. It should always be tilted downward, moved forward and laterally. The internal incision, that is the corneal end, should always be parallel to the limbus. So I would like to conclude by saying that pre-existing astigmatism can be surgically corrected by your scleral incision cataract surgery, and corneal incisions are very stable. Unlike corneal incisions, the incision on the steeper meridian, it reduces the post-operative astigmatism, and length and the size of the incision can be titrated based on the nuclear density. Thank you. Thanks for your kind attention.
Thanks, Dr. Dev, for beautifully covering a very tough topic of, titrating the tunnel. And
that was a very succinct presentation.
I'll request Dr. Shweta Singh to load the videos. And in the meantime, Dr. Dev, can you tell us what kind of astigmatism you will get in different kinds of incisions that you explained?
Yeah, the most common astigmatism is against the rule astigmatism.
Is Dr. Shweta Singh around? Is she here?
Shweta is not able to join us today. She has her OPD.
Okay, what do we do? We'll skip the lecture?
We'll move to the next one.
Fine, we'll cover CCC in the other one in forthcoming lectures. Can I request Dr. Mukesh Kumar to upload his videos? Benefits of SICS over phacosurgery in hard cataract. Dr. Dev, can you answer that question?
Yeah, the most common astigmatism is the against the rule astigmatism if you are putting a superior incision. And then if you put the incision at the steeper axis, that is either the superior or superior temporal, then the astigmatism is neutralized. You can get around 0.75 to -1 diopter astigmatism.
Okay, what is the preferred site of incision in your case? Anyway, you said it's steep axis. And then you also said that the steep axis is horizontal in most of the elderly people. Would you like
Yeah,
to do a temporal incision in all these patients, or would you like to go with the superior incision?
If you have the keratometric readings with you, then ideally you can go to the steeper meridian and put the incision. But if you are not accessible to the keratometric readings, you can put a superior temporal or a temporal incision in all cases.
That means most of the surgeries you want to do it from temporal approach because the horizontal meridian is most of the elders. Is that what you're trying to tell?
Yes. Yes.
Fine.
Yes, sir. Yes, sir.
Yeah, and see the temporal incisions in SICS has been a standard thing now in many of the centers, and I've not gone through the upper incisions for a real long time. We don't have to take a superior rectus suture at all, and temporal incisions are initially you will have you hesitate to do it because we are comfortable in keeping our hands on the brow and operating on it. Here there is no brow, no forehead, so your hands are hanging on it, but then there is a way to come out. But everybody who is doing SICS has to at some point of time shift to temporal side, as he rightly mentioned. The steep axis in most of the adults, elderly group is on the temporal side. And also it's very convenient for handling the instruments.
May I speak?
So you do temporal always, Ravindran sir, nowadays?
Yes. Yeah, 100% of the time temporal.
Wow.
May I speak, Dr. Ravindra?
Please, sir. Please, sir.
Yes, sir.
You know, the temporal incision in SICS being like 6 or sometime 5, like it's a large incision and sometimes you have to suture it and all. Anyway, I find superior temporal is virtually, you can control this one. And I would like to ask, tell Deva Prasad that really don't go behind that much in the sclera that you have to do. I generally do frown with the radial cut upward. So radial cut upward 1 millimeter and frown 5.5, which is about 2 millimeter or 1.5 millimeters starting from the limbus center, and then go like this. So it works like a string and doesn't allow the ATR to happen. And it has been published, and we do it proven. We published in 2009 IGAO that the Blumenthal does straight incision and then upward cut. We do frown incision and then upward cut. It adds to the strength of string pulling it upward. So ATR can be prevented.
Thank you.
And somehow pure temporal incision, I am not in favor of the pure temporal incision for SICS. My opinion, and I don't do it.
Sir, even I have not done that many temporal, but people say that it is very good, but I don't know. I still do most of my superior one. But
yeah, superior temporal,
or the steeper,
right eye or left eye, yeah, I prefer superior temporal. You can get the effect of the temporal because pure temporal incision is a bit risky in many ways. Firstly, it is a red. Patient won't like. My patient should look like that it has not been operated. It should be under the lid, and it should look like that phacoemulsification or whatever surgery has been done, but no surgery has been done virtually. So if you have a superior temporal and you have put your like a flap very well back with a suit with a glue or something, then it will be white eye, absolutely white eye. And you know the phaco came because of that only, that we need a white eye. When you put a temporal SICS, firstly, even phaco also, I don't prefer the temporal incision at all, really. Temporal incision is unsafe. It's likely to give fish mouthing. It looks ugly. It looks red. And all the village will ask you what happened, who has cut you. So,
no, sir, it is quite safe, but yes, it is not very cosmetically appealing. That is true. Yeah.
Okay. Let us have Dr. Mukesh Kumar talk about his surgery.
Yeah. Good afternoon, everyone. I'd like to say thanks to the organizing team for giving this opportunity. So, we all doing the various type of surgery, including ECC, SICS, and phaco. But I'm just going to make you comfortable in your operation theater by just trying to explain why the SICS is sometimes better than the phaco surgery. So as we all know, the manual SICS is safe and effective in white cataract and intumescent cataract. And
Sir, we have lost your voice.
Sir, I'm audible?
Now you're audible, yes.
we can.
Now again we lost.
Hello, audible?
Now it's audible. Now it's audible.
Yeah, okay. I'm sorry for this interruption. So the SICS is very effective in brown or black cataract. As we know, we need higher energy when we are doing phaco for brown and black cataract, which may give rise to the endothelial damage. So in this situation, the SICS endothelial.
Sir, the voice is not there. I think there is some loose contact somewhere. The voice is not there.
So try without headphone.
Dr. Mukesh, we see the slide, but we don't hear you.
Okay, we can lip read you. Read it. Keep on speaking or moving your slides. We can lip read you. What you are saying.
No, we still can't hear you. You talk to the computer directly without the plugin, without earphones. We can't hear you.
I think he can't hear us.
Is Dr. Madhavi Rao ready? We can take Dr. Mukesh later. SICS, my savior at times. Is Dr. Madhavi Rao?
Yes, sir. Yes, sir.
Fine. Dr. Mukesh, can you log out and try to fix your presentation? We can have it again later. Please stop sharing. Yeah. No, no. We see a video. You can play the video if you wish to. Okay. Dr. Madhavi, you can.
Yes, yes. Just a minute.
Dr. Mukesh can't hear us also? Can he?
No, there is a noise on Mukesh. You can mute Dr. Mukesh. Please mute yourself.
Mukesh.
Dr. Madhavi?
Just a minute, sir. I'm trying to do it. 1 minute. But I'm not seeing my 1 minute. Yes. Just a minute, sir. Is it being seen, sir?
No.
Is my presentation being seen?
No, no, it's not visible.
Not visible.
No.
Just a minute. I've been trying to share it.
No.
Now?
No. Still no.
Okay.
It's now coming. Yes.
It's visible now, sir?
Yes, yes. You can go ahead, doctor.
Yes.
Thank you.
Is a full screen visible?
No.
Yeah. Full screen is visible.
Just a minute.
You
Okay.
can come.
Yeah.
Yeah.
I think it's visible. Is it visible, sir?
Now it's visible. Please.
Yeah, but I think my camera is not working and my video also is not working. I think I'm not being seen there, but I think you can hear you.
Yes.
Okay. So good afternoon, everyone. I'm Dr. Madhavi Rao from Vijayawada. I thank the organizers for having me here, and it's indeed a pleasure to be in my in the session, which is very favorite to me. SICS is my savior many a times. So let us consider a scenario wherein an elderly male patient comes to me, unhealthy cornea with dense arcus, not a very well dilating pupil, a shallow chamber, which lodges a dense black-brown cataract, and the vision is PL, PR, and hand movements only. Now the patient's attendants tell me they want the best for their father. Doctor, you do whatever you think is the best. They never ask for a flax or a phaco or any premium IOL. All they say is, we want him to be able to see and do his work without assistance. What are my concerns? Corneal endothelium, of paramount importance, the capsular bag and the zonular strength and its integrity, and the fragile posterior capsule. The complications I anticipate, there could be an endothelial damage, a DM detachment, zonular dehiscence, and a PC rupture. So if any of these are encountered, the purpose is lost and the outcome is going to be compromised, and we often end up delivering less than the patient's expectations. So what is my priority? Safe surgery is my only priority, and my goal is optimum visual outcome and a happy patient. So this is where my savior many a times has been SICS. It's my procedure of choice in difficult situations. What are those? The black and the brown cataracts, the Morgagnian cataract, pseudo-exfoliation with poorly dilating pupil, and a scenario, most of the time we plan a good phaco, but halfway through for certain reasons we may need to convert. Even then SICS has come to my, it's been my savior. So let me come to the brown and black cataracts. You can see the type of cataract we are seeing here. However high-end the machine may be, and whatever skilled surgeon you may be, the surgery is going to be prolonged, and there's going to be excessive ultrasound energy that's going to be used. So there's going to be an increased endothelial damage and a stress on the back zonular complex. So in this type of case, I prefer to do a SICS, wherein I give a good peribulbar anesthesia, ensure a soft eye. Being a SICS, I voluntarily make a larger incision, maybe up to 7 mm, architect a proper tunnel with a large proper inner pockets, generous use of a good viscoelastic, and a large rhexis. As phaco surgeons, all of us aim for a 5.25, 5.5 rhexis, but here consciously make an effort to make a 6 mm rhexis minimum, a good hydrodissection with the nucleus rotation, and also I do a irrigation aspiration to debulk and reduce the nucleus size so that the prolapse and the delivery will be easier. At the end of the procedure, though it is an SICS sutureless, if needed, since the incision is large, I end up putting a suture, a single suture in the infinity form or 2 sutures. There won't be much of an, believe me, the astigmatism can be very well managed and it won't be much. Moreover, the integrity of the wound will be really good. The second type of cataract where I prefer SICS is Morgagnian cataract. In this, you can see that it's a hypermature cataract with weak zonules, wherein rhexis itself is going to be a challenge. The nucleus, though shrunken, is dense and mobile. And the PC is at threat because there is no cortical and epinuclear cushion and the zonules are weak. So here I do an adequate incision depending upon the size and the hardness of the nucleus. And the side port rhexis is preferable here so that the AC is maintained at all times. Initiate a small rhexis, wash out all the loose cortical matter or the milky fluid, decrease the interlenticular or the back pressure, and then again reform the AC adequately and enlarge the rhexis to the required size. Later, I proceed with caution as the capsular bag zonular complex is weak in these cases. The third case is a pseudo-exfoliation. May have done thousands of surgery, but when you see at the slit lamp PXF case, a caution bell rings. Be careful, it's a PXF. Because it's usually a surgical challenge with poorly dilating pupil, shallow chamber, hard cataract, weak zonules, and also sometimes to start with phacodonesis or a mild subluxation. In such cases, do an adequate viscodilatation. Pupillary devices can be used, or just a stretch pupilloplasty or multiple small sphincterotomies also, if not available, the devices are not available. That also serves the purpose. I have done it many times. Rhexis is concentric to the pupil so that all the movements, all the next steps are visible. Ensure proper hydrodissection. This is very, very important. And also a proper rotation in of the nucleus in the bag so that there's no adhesion anywhere and your prolapse will be very safe. The remaining steps are similar to any other SICS, but again, caution has to be exercised while doing IA because the cortical matter in PXF is a little more sticky. The fourth scenario where SICS has been my savior is, I start off with a beautiful planned topical phaco, but somewhere midway through, I need to convert into a SICS. SICS here gives me the advantage of both an ECCE being a larger opening and phaco in the form of being sutureless and closed chamber procedure. When do I convert? Sometimes there is a escape of the rhexis and I'm not able to continue with my phaco. There can be PC tear halfway through and nuclear pieces are still in the antechamber. A prolonged surgery with corneal hydration makes visualization more difficult. And lastly, sometimes it does happen, phacoemulsification machine failure. So by converting into SICS, the surgery can still be completed safely with none or maybe 1 or 2 sutures. How do I proceed in this case is fill the antechamber with visco, Give adequate local anesthesia, because to start off with as topical, but maybe the patient requires some anesthesia. So you augment it with some local anesthesia. And the entry site can be a fresh entry or continue in the same plane by doing a tunnel. And then proceed as per the stage that we encounter. And then nucleus management also. Similarly, cortical wash can be from the main port or bimanual. If you want the tunnel is not so good, then you can make a bimanual and the chamber will be better maintained. Vitrectomy if needed. And IOL can be placed similarly in the bag or the sulcus as per the situation. To conclude, results with SICS are very good even at learning stage. In the learning period also it's good. But once the learning curve has been negotiated, the results are extremely fascinating. Even in complicated cases that I mentioned and difficult situations. Learning and mastering SICS, I learned, is a must even for an experienced and skilled phaco surgeon, because many a times we do need to convert. It has been my savior in many difficult cases. Thank you for your patient listening. Sorry, my videos are not working.
Thank you, Dr. Madhvi Rao, for an excellent presentation. Dr. Parikshit, would you like to comment on this? How this SICS can be a savior in your surgeries? Dr. Meeta Joshi, who is a moderator, would you like to comment on this? Dr. Meeta?
Yes, sir. The thing is, it definitely is very helpful, especially when you have cataracts where you don't know the status of the zonules. Plus, the endothelial count, we are not able to do it in all cases. We may or may not be able to have the machine with us, or whatever the reason may be. But in those cases, especially when you have a good viscoelastic, it is definitely a very boon for a surgeon. And hard cases, definitely it is a very safe alternative.
Dr. Saab, Malik Saab? You have to unmute, doctor. Unmute. You're muted.
Yes, yes. Dr. Madhvi, I appreciate your everything, whatever you've done. And I personally believe that so many patients are, by choosing, you must do the SICS and not the phaco. You want to save the cornea? These hard, the cases she showed, the hard ones and the Morgagian hard ones, and where endothelium is compromised, you must not try at all the phaco. I tell you one patient, and very shortly, that one doctor's father from Chandigarh came to Delhi, went all around, one-eyed person, high myope, with very hard cataract. And somebody told him from Chandigarh, a student of mine, Dr. Sunandan Sood, that so he referred him to me. And then I did the superior tempora. I started from sclera, and so high myope that sclera opened like a slit, complete like this. I had to suture it with 3-4 sutures. And then this time I had to do a temporal SICS. And virtually I had to take the lens nucleus piece by piece. I had to cut it in many pieces to remove it and save the eyes. And thank God that this patient got 6/9 vision uncorrected next day. So some patients I would definitely tell what Dr. Madhvi is on. I personally tell patients that I'm not going to do phaco at all. I'll do the SICS and possibly no suture, or maybe a suture also. So there are absolute indications for SICS. So, and contraindications for phaco. Thank you, Dr. Madhvi. Very good.
Dr. Saab, Malik Saab, would you like to present now the combined surgery for the next 7 minutes?
If I can find out, I don't know. I'm no PG with me, no wife with me, nobody with me.
Okay, then we'll take Rakesh Shakya.
Yes, sir.
Excellent
Good
surgeon.
afternoon.
Kindly share your presentation, sir.
Okay, so thank you, sir. I would like to thank especially KP Malik sir and Namrata madam and Navinda sir to give the opportunity. I am sharing the screen.
Nice to see you, sir, Dr. KPS Malik, after such a long time. Sir, you're muted. We can't hear. Sir, muted. Sir, aap muted ho.
I was in Corona Land, America. Long time.
Yes, sir. Yes, sir.
My screen is running.
Visible. Very nice. Very nice.
Yes. So I am talking about the safe SICS in the 2 minutes.
You are the genius, Rakesh. 2 minutes.
Thank you so much, sir.
He is the champion of SICS.
So in the developing country in India, large population where the unmet need of the cataract surgery, where the high. So the blind people in India, 9 to 12 million people, and blind due to the cataract is the 50 to 80%, as you all know. So 3.8 million people is added per year. So we demand the cost-effective and fast and reliable method. My slide is running because
no, it is not.
It's stationary.
It's okay.
No, it's not running. Good afternoon, Namrata. Okay. You have time to visit all your sessions?
I'm just hopping from hall to hall and seeing how it's going. That's all.
Now the second slide has come.
Yeah.
Third slide, yes.
I think you have to play.
It's okay. So as you see, that there is the backlog of the cataract surgery in our areas also. So this is the COVID area. Slightly I divide the OPD in the many parts. So we follow we actually operate the people. And then, so I want to show you how to do the cataract surgery in the 2 minutes. So I start with the side ports, always in the visco in the entry chamber and deep in the chamber. After that, tighten the bridal suture and then make a incision. It is slightly supratemporally. And then after that, we make a front step incision about it is the 5.5 to 6 mm. And then with the help of the crescent, we advance into the cornea and make a side pocket, and after that we enter the side pocket. So it is the tunnel is become very smooth, and after that put the visco and make the circular capsule axis with the Uttara forceps. So this is the unedited video, and then after the axis we relapse the nucleus in the antechamber. And then put the visco over the nucleus and behind the nucleus. Then deliver the nucleus with the irrigating bacteria. And lens matter is aspirated with the help of the Simcoe cannula. And then I always implant the IOL in the saline. So we keep the Simcoe cannula in the side port and deepen the chamber. And then after that, leading haptic should be in the back, and then rotate the IL with the help of the Cinskio. So this surgery is completed in the less than 2 minutes. So how to actually develop this technique? So we have the fixed protocol to do the surgery and fixed surgical step. So by the time the surgeon is developed this skill, so we need large infrastructure, and trained assistant also is the very important. So this is the this is the slightly white and mature cataract. You can do very easily. So some surgeon actually we divided the cataract in the 2 or 3 category, like in the slightly less simple cases or slightly complicated cases. So the simple cases can be do easily in the 2 or 3 minutes, and when the case is slightly like intermittent or slightly complicated cases, it will take slightly more time. But this type of the cases, we make a side pocket is very important. So we slide the nucleus very large. Large nucleus can be slide very easily. And the rexis always make with the Uttara forceps, because it with the cystitome it will take slightly more time. In the hypermuch cataract, we can also not need to hydrodissection. So then put the visco over and behind the nucleus, and then deliver it with the irrigating bacteria. So this is the another video we can do in the 2 minutes. So we divide in the case like I told initially. I divided the case into two categories. Very simple case. So with simple case can we do very easily in the first session, and then complicated case and divide to refer to the seniors.
Senior to you, whom you refer?
Yeah.
हमारा senior कौन है जिसको refer करते हो?
No, sir. This is the so actually we divide the case in the simple and slightly more complicated case. So we can do the surgery in the large population, because during the training period, every surgeon follow the same protocol. So we actually do the 8 and 1,000 operation per day. So why this reason we divide the two categories. Thank you so much, sir.
That's amazing, Dr. Rakesh. Dr. Arun, would you like to comment on it? Dr. Arun Sangal, you will unmute. Arunji, Dr. Kiran is here. I think that's a fabulous pleasure. Okay. Would you like to give your observations, madam, Dr. Kiran?
Yeah, all I can say, it's an absolutely amazing whatever he has shown. I mean, and you have to be extremely well trained to be able to do this kind of a surgery. And
thank you.
So I think we are just bewildered by his expertise.
They do it so many every day. They do it so
Yeah.
many.
Like we are also doing SICS, but I don't think 2 minutes has been my this thing. But my only caution would be that let the youngsters, the residents, not try and emulate it till they have become well trained enough for it.
No, ma'am. Actually, madam, during the training period, every surgeon follow the same step. Actually, we fix the steps of the surgery. So after the 1 year, 2 year, the surgeon becomes slightly confident and do the surgery in between the 2 to 5 minutes. So we can remove the load.
Rakesh, I would like to ask you that you make a side incision which is quite large, through which you put the Simcoe cannula. So it might be more than 3 millimeter, in fact. Did you have anything to do with that? Did you really measure the astigmatism postoperatively that this particular incision induces? Where you make the side port. Generally, I make side port with a just triangular, those which are meant for MVR. But you made it with a larger, this one, maybe more than 3.5 millimeter, where you are entering the Simcoe. Does it have effect on your cornea as a curvature or astigmatism? Did you study some of these patients for astigmatism? You make a side incision which is large.
Yeah, I think Dr. Rakesh, you'll have to unmute. You are muted. To answer the question, you'll have to unmute.
Okay,
Dr. is asking, you have made a main tunnel, you have made a side port, which is approximately about 90 degrees away. What is, if side port is larger in size, so will it have any effect on the astigmatism? Is 90 degree away side port, large side port neutralizes the main astigmatism that you're causing, or is it worsening it? That's what he is trying to clarify. Have you done the study? The second is, before you answer it, if you get a raw hand, like somebody who has just finished a MS and joins you, how much surgery, how long it will take, or how much surgeries, how many surgeries he has to perform before he reaches the perfection of the speed as well as the quality?
So, sir, actually, in the winter season, actually, we need the more surgeon. So, more surgeon actually to operate the slightly fast surgery.
आजकल क्या कर रहे हैं आप कोरोना के दिनों में?
No, sir. Nowadays the condition become similar at the last year. Today's the operation list is about the 800.
नहीं, कोरोना से नहीं डरते आप लोग?
No, sir. I have the corona different corona center. Every patient come through it.
He is a PTI, the RT-PCR done?
No, sir. Just screening.
Screening means what? How are you? You have temperature.
Actually, every patient RT-PCR is not possible, sir.
I know that, and it's a controversial, but think of America, that you have 3 lakh patients every day in America. And I don't know really whether this pre-testing is done in AIIMS Rishikesh. We were not doing any patient there without testing the corona. And corona negative patients are only being put in surgery, any kind of surgery, including ophthalmology.
Is Dr. Swati Pandey ready for presentation? She's going to talk to us on SICS tips for beginners. Maybe after that we will discuss for a few more minutes. Dr. Swati?
Yes, sir.
Yeah, can you share your screen?
Sure.
I would, Dr. Ravindra, find my slide, the video if I can put it. I will put it first.
Please, sir. Please, we
Yes,
still
sir.
have
Yes,
time.
sir. Please,
We still
sir.
have time.
It is there somewhere. Yeah.
Swati, can you share?
Yes. Good afternoon, everyone.
Good afternoon.
I hope I am audible and my screen is visible.
Your screen is not visible, doctor. You have to share the screen.
Just a minute.
You have to select this share screen and then
I see. Yes.
Is Dr. Mukesh Kumar, are you ready for?
Give me a moment.
Sure.
Is it visible now, sir?
No, no.
No, screen is not visible.
In the meantime, Mukesh, if you're ready, if you'd like to present yours.
Can you hear Dr. Mukesh?
No, he has difficulties.
Yes. Ravindra, how do I find my slides and put them here?
Oh, okay. We got SICS tips for beginners by Dr. Swati. We can see your slide, doctor.
Okay. Thank you, sir. A very good afternoon to you all. And Dr. Rakesh, it was a very beautiful, beautiful surgery. It reminded me of my good old Arvind Eye Hospital days. Monday OTs used to be like that. So basically in my presentation, I will be just sharing some simple tips for surgeons who are about to begin their SICS journey. I will not be going into much detail of the technique because it has been already dealt very nicely with the previous speakers. So a good surgery always starts with a neat conjunctival dissection. So the conjunctival dissection in SICS surgery should be just bigger than the planned incision. If we do an excessive dissection, it will lead to poor hold during the surgery, and it will also cause difficulty in approximation of flaps at the end of the surgery. So what we were discussing about giving a white eye to the patient post-surgery, that steps becomes difficult. Even when we make a good sclerocorneal tunnel, we think that we have done a good job. We have considered the astigmatism aspects. Our sclerocorneal tunnel seems to be a good size also. But sometimes in the later steps of the surgery, we land up with difficulties, especially during the nucleus removal. So the main problem is, as beginners, we tend to fail in making the side pockets. So making side pockets is very, very essential after constructing a good scleral corneal tunnel. If we tend to fail in making a side pocket, then instead of a trapezoid configuration, the sclerocorneal tunnel attains a bottleneck configuration. This makes nucleus delivery extremely difficult, and in anxiety, when we are trying to do forceful attempts, it can lead to iris trauma, iris prolapse, PCR, and a very difficult and complicated surgery. While making the AC entry, we should be very sure that we are making a straight AC entry with the keratome. We should not turn the keratome excessively while extending the AC entry. This step is very important because oblique entry and excessive turning results in irregular or a triangular inner lip, which loses the self-sealing valve effect. It leads to a bad DM detachment, not a good thing to happen. It also causes post-op astigmatism. When we are doing the SICS surgery, the non-dominant hand is holding the forceps to maintain the globe stability. So as we are concentrating more on the SICS steps, more on what we are doing with our dominant hand, we unknowingly tend to press the globe excessively with the non-dominant hand. This leads to opening of the wound, causing AC collapse and making the intraocular steps quite difficult. So this is something we all know, but we tend to forget when we are doing a surgery, and then we are struggling with our steps. The anterior chamber should be always maintained during capsulorhexis. So as a beginner, we should not be, just looking at the good SICS videos where the surgeon has, inflated the AC only once, and he or she is able to do a good capsulorhexis. So when we are a beginner, we should always make it a point to keep inflating the anterior chamber as soon as we notice any shallowing. Any shallowing in the AC causes positive pressure from the vitreous, the anterior curvature of the lens increases, causing poor control over the rhexis flap. The rhexis may extend, and we may end with a posterior capsule tear. The size of capsulorhexis is also very important. I remember when I was a beginner, sometimes I used to actually measure my rhexis during the time of surgery. So generally, the crystalline size dimensions are like, the lens is about 9 to mm in diameter. The thickness is 4 to 5 mm. So when the purpose of the capsulorhexis is that its size should be adequate, and we should be able to nicely prolapse the nucleus from the nucleus into the anterior chamber so that we can deliver it out. An ideal size would be 5.5 to 6 mm. It should be larger in hard cataracts. Beginners can begin with a larger rhexis. It really makes hydroprolapsing the nucleus into the AC easy. And when we are able to finish our surgery smoothly, so our self-confidence also builds up, and maybe all of us, all the SICS surgeons can become fast surgeons also. So multiple forceful attempts to prolapse the nucleus, if the rhexis is small, will lead to zonular dialysis and rhexis tear. When we are removing the nucleus, we should always be able to visualize the inferior rim of the wire vectis. It should be clearly visible beneath the nucleus. We should really engage it, visualize it, and then pull out the nucleus. Not paying attention to this step may end up with iridodialysis. After the nucleus has been delivered, we have to do irrigation aspiration of the cortex. So some useful tips are: never depress the inner lip of the wound, as it causes wound gape. It will lead to leakage, shallowing of anterior chamber, and a difficult and unsafe irrigation aspiration. Also, always hold the cortical fibers by its anterior part. Never try to catch the posterior part, as you may end up with PC touch and a rent. IOL implantation should be always attempted in a nicely visco-inflated bag. So inflate the chamber nicely with the visco, see the PC falling back, and then implant the lens. Also ensure that you have placed the IL correctly before closing the wound. As beginners, sometimes it does happen that the haptic has not been dialed nicely into the bag. So always check to these things before closing the wound. This will lead to good results. So this is all about in my presentation. Thank you for your patient listening. This presentation was basically meant for beginners.
Dr. Malik Sahab, you train so many people, and could you add some of your tips as to how to teach the youngsters and how to make them do surgery without causing any damage to the eye?
Mostly what Dr. Smita has spoken, it's a valid point she has given. Only thing is, like, my procedure, of course, is with the anti-chamber maintainer all the time.
Okay.
So I anti-chamber maintainer, so my fluid and my chamber is always formed. And I was wondering that how she measures the rhexis, because rhexis can't be measured as through the outside the cornea or even inside the cornea. That reads very sophisticated things. But generally, for beginner, it's very easy to say that make a larger rhexis. But larger rhexis is very difficult. As you go periphery, more and more dense zonules you will get. The zonule free area is only 5 millimeters in front of the lens. Rest it is all zonules. It's a slightly rarer and then become denser and denser. Maybe that beginning I would tell them to do the small rhexis and give the kind of a coma cut 2 or 3 places so that it doesn't run away during the hydrodissection and still retains the bag. So that is why I generally tell students about the tunnel making. I would always say that don't start from far off. In the beginning, I say that you start making tunnel right at the limbus or a half millimeter or 1 millimeter behind the limbus. And then it's easier for you to manipulate the tunnel going in the cornea. And of course, I tell these boys that think of that when you take a crescent in the cornea, that as your flight is taking off, and the plane is going up like this. So you have to go with the curve of the cornea upward and then side to side. So that way you would not have the uneven corneal dissection, you would not have premature entry, and you will have a very good corneal valve. So these two basic things are very essential for making the tunnel, that you should know the cornea curvature when you are passing your crescent. And third, I tell you that when you enter the chamber, your keratome should be cutting while going in, not coming out. So mostly go in, cut, go in, cut, go in, cut. And it should be so fast that your chamber doesn't collapse, whatever you're doing. You don't have to do it again and again. Once you're, say, you make a mistake, say, for example, you have a little premature entry and you start having the iris out, and you keep on pushing this iris again and again, it keeps coming, and it makes surgery difficult even for very experienced people. So beginning, we try to tell them the small rhexis, making tunnel properly, and we go step to step. That we give them the first tunnel making for many days, then rhexis for many times. So these steps has to be added one by one like that. And I won't mind that a beginner has to do no capsulorhexis and he can do the can opener. Can opener also, I tell that start in the center, very small cuts, so many of them, 70, 80, 70, 80. And when you do the rhexis, it spreads out like that, and it virtually behaves like a capsulorhexis. Though there are cuts like this, but if you start from center, then it will be, though it is not a capsulorhexis, but it will behave like a capsulorhexis when you do the hydrodissection. And you can take out any nucleus out of it. And there is no problem that if you do the like can opener, proper can opener, or there's a kind of envelope technique also. So you can do that. So beginner, I believe that teaching is that we created surgeries, we created complications when we learned anything. My aim is that my students should not do those complications which I did. So that is my aim remains. That what I spoiled the eyes, that my children should not do that. So that is what it is.
Excellent comments. Dr. Rakesh, can you tell us how exactly you will take your guide your students?
in the beginning period, it is very difficult to make a front-shape incision. So the beginner always start from the straight incision. Don't worry about the astigmatism. So this is my take on this. This is the tips.
And what is the first step you give to the postgraduates? So when they come here after completing the degree, what do they start with? And what do they graduate? What do they graduate? You don't give the entire surgery, I'm sure about it, but how do you progress them? Would you give lens insertion first, or would you like to give the tunnel first or the capsular rhexis first? How do they promote themselves?
So I think the tunnel is first. Tunnel is the main part to. It is a very important part of the SICS. So we always start from the tunnel.
Is Dr. Abhishek here? Abhishek Onkar? I don't see his name.
Make the tunnel,
No,
but
he's not there.
entry into the anterior chamber. You make the side port and do the rhexis from the side port. Just dissect the tunnel, leave it. Don't enter the chamber. That's what we do. And then we make the side port for the student and say, now try rhexis. So we'll go later on for those ones. Anybody? So I have to look up this one now?
Yes, sir, you can.
So let me find out. It was on my desktop. If I can bring it here and then play for you. Meantime, you can continue something. I'll search. Okay. If you have something. I don't know. I could not load it right on the screen sharing. I don't know. Can it be shared on my desktop? Can anybody guide me how to bring it here?
In the meantime, as he's searching, I can show the video that I'm going to do.
Okay.
Are you able to see my screen?
Yes.
Yes, sir.
This is what I was trying to tell, that this is, I'm sitting temporally. There are no superrectors. These are the lower lid and upper lid. I directly take the incision from the anterior sclera. It goes across the limbus and gets into the cornea. Then I'll dip the tip of the keratome inside and I take it up again so that anterior and posterior tunnel edges are parallel to each other. This is a tunnel floor entry. I'm not taking through the tunnel, but I'm going through the floor of the tunnel here, entry at the limbus. AC is filled with viscoelastic. I'll go fast. And rhexis we missed. This is how, for doing a rhexis, you should have a deep chamber. That's very important. Here, it's a tunnel which is not leaking. AC is very deep and you can go and complete the rhexis in one go. How do we measure the tunnel size? The corneal dome magnifies the rhexis size. If rhexis size is 5 millimeter, actually you'll be seeing it as 5.5, 5.75 on outside. So your actual rhexis size is smaller than what you see from outside. So if you take a 6 millimeter measurement or a ring or a mark on the cornea, you'll be actually doing 5.5. This is an enlarger, and then hydrodissection, and quickly finish it and rotate the nucleus, bring it out into the anterior chamber. There's no hemorrhage here. Visually, they look as good as any other surgery because you've not gone through the conjunctiva antenons. These are very special wire vectors through which, without damaging the endothelium, we can take it out. I'm continuously injecting viscoelastic to protect the endothelium, and then aspirate the cortex, and you can put a multifocal lens. This one produces about 0.5 to 0.7 diopter of astigmatic correction, SIA. So I'm doing it on the scleral side, and the patient will end up. So you can see the size of the rhexis is smaller than the lens. It's a multifocal lens, and there's no need to bandage the eye. You can leave it open. Take out all the viscoelastic from the capsular bag and the anterior chamber, and that's the end of surgery. So you can give marvelous results even in such patients. There's another video which I would like to show what Dr. Malik said. Intumescent cataract, enter it at the go inside and tunnel floor entry. Now air followed by trypan blue. And this is what Dr. Malik Saab said. you aspirate the trypan blue. Don't inject viscoelastic to expel the trypan blue, then through the weak zonules it can go. This is exactly what Dr. Malik said. You can make tiny punches just with the tip of the cannula. You can make a very small rhexis there and then let the milk come outside, aspirate it out, and you disturb the anterior cortex, rotate the nucleus. Then there is a flap there, as you can see. You can hold the flap, and then now you can do the rhexis. This rhexis also is smaller, so I'm initiating one more rhexis here and making it adequately sized so that that's the second rhexis. Lignocaine into the eye, being done under topical anesthesia. Rotate the nucleus and bisect the nucleus, and then you'll be able to take out each piece. Endothelium has to be maximally respected, and then you can put your lens inside the eye. So I just wanted to show these two videos so that you can take home that SICS can be promoted to higher scales. Yeah. I think our session is getting closed. Is Dr. Malik? Are you able to share your screen, sir?
I can't see sir now.
Dr. Mukesh?
Yes, sir. I'm audible now?
You're audible very much now.
Yeah.
You can present.
Good afternoon, everyone. Again, I'm very sorry for this connectivity issue. So can I share my screen now?
You can, but I think we have only about 3-4 minutes time if I'm ready.
I will try to finish as early as I can. So, see, we all are well trained in ECC, SICS and phaco, but in some situation, SICS are better than other surgery because it is a suture-less surgery. And like in some situation, like white, hard cataract, intermittent cataract, the phaco energy is little higher when we are doing the phaco. So you may have post-op corneal edema and the endothelial damage also. So in some situation, the SICS are better. And like in the black and brown cataract, the SICS technique is much better than the other technique. And in the phacomorphic glaucoma and phacolytic glaucoma cases, it is you can say a choice of for the patient, but there are some demerits also for the SICS. The conjunctival congestion may persist for a long time, and patient may have tenderness resulting from the scleral incision. And sometimes, if there is a tunnel is not good, you may have hyphema, and definitely the surgical induced astigmatism is more with the SICS than the phaco. So I will going to share some video in for some difficult situation, like in the case where you have the fibrous anterior capsule and the hard cataract where the phaco is little difficult. So you can easily try for the SICS surgery as we need a good capsulexis when we are doing the phaco. But in these situations, you can easily cut the anterior capsule either with the help of Vanna scissor, or if you can try, you can do the capsulexis also. So very easily you can remove this hard cataract from the eye, and these are very safe. The next day you will have a good outcome in the cornea, clear cornea. In few situations like where you have the leukemia adherens and with the small pupil, where the phaco is really difficult, and because you are dealing with a small pupil, you can try the iris hook, but in the SICS technique, you can easily modify your steps, and you can easily remove these cataract. Like you can release the in this case you can release the leukemia adherens, and you can enlarge the pupil, and you can do the rhexis, and very easily you can remove the cataract without damaging the cornea. So few situations really need the SICS technique, which you cannot do when you are doing the phaco, because these cases need the higher energy, and you may not have clear cornea on the next day. So like in this video also, I'm removing the hard nucleus from a small pupil area, but we have the larger tunnel, so we can easily remove this cataract. So I'm playing my video very fast because we are having the less time now. And the IOL implantation is very easy with the open tunnel. So we'll share few more video with all of you. The situation when you have the sclerocornea, where you have the limited visibility and the very hazy cornea. So the phaco is really very, very challenging in this situation, but one can try, because with this much of visibility, you can easily do the rhexis if you are good in making the rhexis, and you have the enough space after making the tunnel, you can easily remove the cataract with the help of wire vectors. Kind of situation really difficult when you are planning for the phaco, but SISs give you a comfort zone. You can easily remove the cataract with safety, and you can easily implant the lens. In the situation where there is cases like keratouveitis, post-keratouveitis cases, where you have the hazy cornea, you have the small pupil, you're having the hard cataract. So really the phaco surgery is really difficult to perform in this situation, but one can try the phaco also, but the steps in the SISs are very, very, very easy. The patient is very safe when you are dealing these situations with the SISs technique. Like in this case, the cornea is not so good. So if we try with the phaco, definitely you need a higher energy, and you may have corneal edema in the post-op period, and sometimes higher energy may cause the endothelial damage, and you have the corneal decompensation also. But with this technique, you have the advantage. In the few situations where you are dealing with the subluxated cataract, the chances of drop are much more when you are doing the phaco. So, but in the SISs, you have liberty. You can lift the nucleus after making the rhexis. You can easily remove the cataract, and you can save the drop. All the rest of the steps are same as we are doing the phaco. You can implant the CTR, and you can implant the lens easily, as we all are doing. We are all following when we are doing the phaco in the subluxated. But in this situation, you can easily prevent the drop because you have the open space. So the chances of drop are much less with SISs. We'll share a few more video also. Like when you want to convert your phaco, so you have the complication during the phaco, you have the large PCR, and still you have the nucleus, part of nucleus in the anterior chamber. So you have two choices. You can enlarge the section, corneal section, and remove the rest of the nucleus. But this enlargement of section will give you, will need the sutures at the end of the surgery. But if you know the technique of SISs, you can easily convert the case in the SISs. So after converting, you can remove the nucleus, the part of the nucleus with the wire vectis, and you can do the vitrectomy if there is a vitreous, and can easily implant the lenses in the sulcus. In post-trap cases also, when there is a small pupil, very hard cataract, like in this, there is a brown cataract. So one can try the temporal section of SIS. Although this technique is very difficult, people are not in favor of the temporal SIS, but in the experienced hand, in the good hand, the technique is safe. So one can try this hard cataract to remove from with the help of temporal SIS. If you are working in a center where you don't have the phaco machine, or if you are not comfortable with the hard cataract, or if you are not comfortable doing phaco in the hard cataract, you can try the temporal SIS. The technique is same, but you need to learn the technique. In the phaco, you need a higher energy, and definitely a expert person can do the phaco in this situation. Like in this video, the section was made, Rexis was made, and you have the choice when you are doing the SISS also. Suppose the Rexis is not educate or you have the runaway Rexis, you can cut, make the relaxing incision, and you can, like in this, I'm making the relaxing incision with the help of Vanna's scissor. So after making the relaxing incision, you can easily remove these cataract with the help of dialer. You can lift the nucleus into the antechamber, and after that, you can use your wire vectis to remove this nucleus. So definitely one should be mastering the technique before attempting the hard and the difficult situation. But these SISs are definitely much safer than the phaco, as a phaco is a closed chamber surgery. Although we all are doing the phaco in the everyday situation, but definitely these closed chamber surgery having a maximum chance of drop, because in the small pupil surgery, you are not aware about the status of the zonules. You may have subluxation, you may have zonal dialysis, which is unnoticed sometime when we are doing the dealing with the small pupil. All the techniques are good, but sometimes the SISS techniques is give you a kind of safe zone in your operation theater because of less chance of complication. But definitely you need to learn the technique, and it takes time. So I will stop my presentation here because I know. So the technique is good for the mature hard and black cataract, and the benefit over ECC is sutureless, and it in case or if you want to convert, and post-op astigmatism is less, but not lesser than the phaco surgery. So thank you very much, and I'm sorry for this interruption in between the presentation.
Dr. Mukesh, for wonderful presentation. I think we are up with the time, 4:36 already. Dr. Malik, you went away. Is your presentation ready? Can you
No, I'm sorry. Can you hear me?
Now we can hear you, sir.
But just I cannot really bring it back there. I can't do without some PG with me. This is my problem.
Yeah, we are missing your lecture.
I can tell in 1 minute what I mean.
Please, sir, please.
This is mine is a frown incision like this. So in frown, I go like this, little frown, half frown first, and then the flap for trabeculectomy, and then frown again. This is my technique.
Dr. Mukesh, can you mute your mic? Dr. Mukesh, please mute. Yeah, now, sir.
So this is a half frown, then a flap, and then frown, and then dissect it like SICS in the cornea and everything, and then from side port do the rexis, take the nucleus out, and bring the nucleus out. Then I inject the lens first, put the lens first, and then do the trabeculectomy. And my trabeculectomy is that the posterior part of this flap, I don't do punch or anything. I virtually cut 2 vertical line and a horizontal line, and then cut a piece. It's a piece, the quadrangular piece cut from the posterior lip of this posterior flap, scleral flap, and the posterior flap. So that part of flap which is near the angle, that part I cut vertical, and then horizontal, and then pick it all. So it will be a quadrangular, rectangular kind of a piece, which will be about 4 millimeter and about 1 millimeter wide. And then I do the peripheroidectomy and put back the sutures of the sclera flap, and that's all. The sclera flap only. So I find it, and another message I want to give, that when I was doing diploma in Sitapur 73, I made it believe that once you get an Indian patient with glaucoma and a villager, do the surgery rather than go on 1 drug, 2 drug, 3 drug, 4 drug, 5 drugs. No, I used to, as a young man, fight with everybody. English people were coming that surgery is bad, you must do the drugs and all that. But I think surgery is much better than now. The Western people also agree that earlier surgery is better for preserving the vision of the glaucoma patients. And if a villagers or anybody has a cataract with glaucoma, I will convince him that I would do both the things, cataract plus glaucoma together. Whether it's a phaco trap or it is a SICS trap. SICS trap is you do everything in one incision. Phaco trap you have to do separate incision. That you do the trap at one incision and phaco another incision. So that's all my message about the combined surgeries.
Okay, thank you, sir. I think we are up with the time, and my sincere thanks to the BOS, the academic group, Dr. Namrata Sharma, the president, for giving us the opportunity to share our thoughts here. And we're happy that all the presentations went on very well. And bye bye to everybody till we meet next time.
Thank you, sir.
Thank you, sir. Thank you.
Thank you,
Thank you
sir.
very much. Thank you.
Good night, sir. Thank you, ma'am. Malik, sir. Good night. Ravinder, sir. Mata, madam.
We'll keep meeting again and again.
Thank you, everyone.
So no party tonight, party will be next year.
Okay, sir. When are you coming back?
I have come back to India now. I just came 2 days back. I came 2 days back.
Okay.
I was wondering that DOS and AIOS, no parties now, nothing. Corona, really now, even Westerners are saying whether it's a corona or it's just a flu. They're saying it's a different kind of flu, nothing else. It's a flu which harms someone, but it is a flu of different kind. It's a flu of different kind which attacks some people who are smokers, who are diabetic, who have stand, and who have immunity poor. In my village, Western UP, I have gone in village in hundreds, not a single patient. Not a single patient. And Kisan, now they're sitting in lakhs, no corona there, nobody. So corona, don't be scared now. Mask, of course, but don't be scared. Enjoy the life. Happy bye night. Good night.
Okay, sir. Okay, good night.
Thank you, sir.
Bye bye.
Hello. Hello, Durvinder sir. Hello, Durvin sir. Hello. Hello, Durvin sir. Durvin sir. Hello. Hello, Durvin sir. Hello, Durvin sir. Hello, hello.